بسم الله والصلاة والسلام على رسول الله. Welcome everyone to join us today on behalf of the Tropical Diseases Teaching Hospital, the Academic Club, in collaboration with Sudan HIV/AIDS Working Group, SHOG. I warmly welcome you all to this second lecture in our HIV Clinical Foundation series. We're honored by your presence today, joining us from Sudan and beyond Sudan. This series aims to strengthen the clinical understanding of HIV bridge theory with practice, and of course, to promote evidence-based care through shared expertise from local and international specialists. Tonight's lecture is very special. It will focus on the HIV/AIDS Clinical Foundation. This will cover essential aspects that are fundamental for the clinicians, laboratory specialists, and healthcare workers involved in HIV care and prevention. We're privileged to have two distinguished speakers today. My friend, who happened to be my brother, Dr. Sadig Omer. He's internal medicine specialist in Atbara Hospital. He's also a microbiologist in the Faculty of Medicine, the Nile Valley University. He's a recognized and respected lecturer in Sudan International University. And today he will guide us through HIV virology and testing, highlighting the key diagnostic principles and the clinical implications of those tests. Our second speaker is Dr. Nadia Ahmed. She is a consultant HIV and sexual health physician in the United Kingdom. She has experience in adolescents' health care, inpatient care, sexual function, and gender-based violence. She will discuss with us the acute HIV infection and the clinical staging. This will emphasize the early recognition and patient-centered management. We encourage all the participants to remain engaged in our lectures today. Please keep your microphones muted during the presentation and feel free to post all the questions and comments in the chat box. And by the end of the session, there will be a dedicated discussion. Without further delay, I would like to invite our first speaker, Dr. Sadik, to begin his presentation.
السلام عليكم ورحمة الله وبركاته. هيفتح لي السلايد الأولى.
Okay.
تمام. صادق عمر الحسين, internist and microbiologist. Today, inshallah, we are going to discuss HIV introduction, which is composed of three main parts. Part 1, HIV structure and life cycle. Part 2, immunology. The last one is investigation. Let us start. طيب, في السلايد الأولى زي ما قلنا الجزء الأول بارت 1 حيكون فيه شنو؟ HIV structure. التيرم هنا اسمه فيريون. فيريون means virus structure. طيب قبل ما نعاين في السلايد دي أنا عايز أقول كلام بسيط. طيب الفيروس أصلا بيتكون شنو؟ فيريون structure composed of يكون في genome material covered by protein, والجينوم دي it could be DNA or RNA. يبقى from inside to outside structure. معلش الكلام ده شوية كتير لكن بيخلينا نفهم المحاضرة كويس. يبقى from inside عندنا genome structure covered by protein. البروتين ده اسمه كابسيد. لحد هنا up to this point الفيروس بيكون اسمه نيك فيروس. طيب في بلس اور ماينس سيرد اوتر ليتر دي اسمها انفلوب. يبقى عندنا نمرة واحد في الفيريون ستراكشر عندنا حاجة اسمها جينوم دي ان اي وار ان اي وكابسيد بلس ماينس انفلوب. الانفلوب ده اصلا جاي من وين؟ جاي من السيل ممبرين. طيب نحن نستفيد شنو من الاستراكشر ده؟ طيب لما نقول الفيروس دي ان اي فيروس في الغالب بيكون الريبليكيشن اوكير انسايد نيوكليوس، والفيروس ده بيكون عنده هاز ابيليتي تو لايف لونج ريزيرفوار. جميل. ولما يكون ار ان اي الريبليكيشن اوكير ان سيتوبلازم. طيب الخطوه الثانيه الكابسيد. هنا عندنا مثلا الكابسيد في الاتش اي في بيهمنا حاجه واحده البي 24 وده ايرلي ماركر فور انفستيجيشن. والطبقه الاخيره اللي هي الاوتر لاير اللي هي اسمها انفلوب زي ما شايفين هنا باللون الاصفر. الانفلوب ده بيجي من وين؟ بيجي من السيل ممبرين. طيب، قلنا اذا كان دي ان ايه عنده ability for latency for lifelong infection. وهنا الاتش اي في لو لاحظنا هو ار ان اي فيروس، لكن برضه شنو؟ لايف لونج ريزيرفوار. هنقول السبب ليه مع انه ار ان اي، والار ان اي ده ما بتكون كده. طيب، وهي عنده كابسيد طبعا، والكابسيد فيه البي 24، ودي ايرلي ديتكتور ماركر ممكن نلقاها. والاوتر سيرفيس هو انفلوب، والانفلوب بيشيل من شنو؟ دايما الانفلوب بيجي من السيل ممبرين. لما يجي يحصل ريليز للفيروس فروم فيرال انفكتد سيل، يقوم بيحصل شنو؟ بيشيل معاه جزء من الممبرين وبيطلع. هو ده بيعمل له كفر، وبيعمل له ايفيشن فور الاميون سيستم. دي الحاجه اللي بيستفيدها الفيروس. لكن في نفس الوقت بيكون الفيروس very very sensitive للادفيرس كونديشن. سو المود اوف ترانسميشن حيكون ثرو شنو؟ برانترالي. يعني دائما النيك فيروس بتجي من الكونتامينيتد ووتر، لكن الانفلوب فيروس بتجينا من وين؟ دايما الانفلوب فيروس بتكون برانترال ترانسميشن، زي الاتش اي في اللي هو برانترال. دي عارفينها طبعا فيها شنو؟ اللي هو السكس والفيرتيكال والنيدل ستيك. يبقى هنا الفيروس بتاعنا ده هو دي ار ان اي فيروس ولونج ليف فيروس. ليه؟ لانه في نفس الوقت اسمه شنو؟ اسمه ريترو فيروس. ريترو فيروس ده نقول شنو؟ زمان عندنا حاجه اسمها السنترال دوجما. اللي هي السنترال دوجما دي بنتكلم، بنقول الدي ان ايه بيحصل له ترانسكريبشن بيدينا الار ان اي، والار ان اي بيدينا البروتين. طيب الفيروس ده ار ان اي فيروس، ما بيمشي في الباثوي ده، بيرجع يعني من الار ان اي بيرجع يبقى شنو؟ ثاني دي ان اي. حداك يحصل السنترال دوجما بنعرف اللي هي الدي ان اي ار ان اي بروتين. ودي اكسبلين انه ليه الفيروس ده ريترو فيروس، عشان يمشي يحصل له انتجريشن في النيوكليوس ويكون شنو؟ لايف لونج ريزرفوار. طيب، نجي للاستراكشر بتاعتنا اللي هي المكتوبه هنا. قال لك اتش اي في فيريون كونتينز، اللي هي فيريون دي قلنا شنو؟ قلنا عباره عن فيروس ستراكشر، هو انفلوب فيروس. دي الحاجه اللي بتهمنا. وفيه تو كوبيز اوف بوزيتيف سينس ار ان اي. قاصدين شنو ببوزيتيف سينس؟ يعني ريدي فور ترانسليشن. مرات في نوع من الفيروس بيكون نيجاتيف سينس. نيجاتيف سينس ده الا تعمل له ترانسكريبشن تحول لبوزيتيف، والبوزيتيف هو ايكوال الماسنجر ار ان اي، يقوم يديك البروتين. لا، ده ريدي بوزيتيف سينس ار ان اي. طيب، الكومبوننت بتاعته من جوه عنده حاجه اسمها ار ان اي ديبندنت دي ان اي بوليمريز، اللي هو ده الريفيرس ترانسكريبتيز اللي بيحول لي الار ان اي لدي ان اي. وعندنا حاجه اسمها انتجريز وبروتيز. طيب يا دكتوره، السلايد اللي بعديه اللي فيها السلايد اللي بعديه لو سمحتي. طيب، قال لك الريزرفوار، يعني عندنا حاجه هنا، حاجه اسمها التروبيزم. اللي هو التروبيزم شنو؟ الفيروس ده يعني انفكت سبيسيفيك سيلز، خلايا معينه. الحاجه دي اسمها التروبيزم. دي عباره عن شنو؟ بتكون ريسبتور لايجند انتر اكشن. يعني هنا الفيروس الريزرفوار بتاعته التي هيلبر سيلز اند ماكروفيج. والترانسميشن واضح طبعا، اللي هو سيكشوال كونتاكت، اللي هو ممكن نقول برنترال عموما. طيب بعدها نيكست سلايد. طيب، يلا نركز في السلايد دي شويه عشان يكون الاستراكشر واضح. طيب، هنبدا من شنو؟ من الانر موست بارت. طيب، عندنا اثنين حاجه كده لون اخضر اثنين، اللي هو ده العباره عن شنو؟ هو ما دبل ستراند عشان تكون واضحه. الحاجه دي اسمها ديبلويد ار ان اي. يعني شنو؟ يعني تو سيجمنت اوف ار ان اي. ات از نوت ا دبل ستراند ار ان اي. يبقى هو شنو؟ الحاجات اللون الاخضر دي اللي هي مكتوب فيها شنو؟ دي عباره عن ار ان اي، وبنقول عليه ديبلويد. ديبلويد يعني كونتين اوف شنو؟ تو سيجمنت اوف ار ان اي. وجنبها في نقطه كده بلو، دي الريفيرس ترانسكريبتيز. عشان من هنا بعدين لما نخش اللايف سايكل هنتكلم عنها بعد شويه. لما نجي هنتكلم عن اللايف سايكل بعدين هنلقى ان في حاجه اسمها الريفيرس ترانسكريبتيز من الار ان هيرجع دي ان اي. لو طلعنا بره منها شويه هنلقى حاجه اسمها شنو؟ الكابسيد، اللي هو ده وبيتم فيه البي 24 اكثر واحده، لانه ده اللي هي ايرلي ديتكشن ماركر فور انفستيجيشن. وعنده بروتييز انزيم، وعنده انتجريز انزيم. لو طلعنا بره شويه خالص حنلقى شنو؟ حنلقى الحاجه اللون الاصفر التخينه دي اللي فيها زي اللولي بوبس، عصايات الزرقاء وفيها كره، عصايه بنيه وفيها لون ازرق. دي امبيدد وين؟ انسايد اللي هي الانفلوب. يبقى الاوتر لاير دي الانفلوب. الانفلوب بتهمنا في شنو؟ انها بتحدد المود اوف ترانسميشن. في الغالب هو تكون ادفيرس لان هي بارت اوف السيل ممبرين اللي هي فيري سنسيتيف للادفيرس كونديشن. يعني ما ممكن يكون المود اوف ترانسميشن انك تشرب لك مويه كونتين اتش اي في. في الحاله دي انت حتفقد الفيروس، لانه الفيروس ده زي ما قلنا شنو كفر باي انفلوب. عشان كده هو فيري سنسيتيف. طيب الحاجه البره دي اللون ازرق مكتوب فيها جلايكوبروتين 41 اللي هي ترانس ممبرين، والاوتر خالص مكتوب فيها جلايكوبروتين 120 سيرفيس. طيب الحاجه دي بتعمل شنو؟ الجلايكوبروتين 120 ده اللي بيعمل اتاشمنت. زي ما قلنا في حاجه اسمها التروبيزم. التروبيزم اللي هي شنو؟ الفيروس انفكت اونلي اللي هي السي دي 4 سيلز. اللي هي سي دي 4 قاصدين بيها شنو؟ قاصدين بيها التي هيلبر سيلز وصم ماكروفيج اند دندريتك سيل. يبقى الاتاشمنت اللي هي الجلايكوبروتين 120 ده هيمشي يعمل لي اتاشمنت مع السي دي 4. دي الخطوه الاولى ودي بنقول عليها شنو؟ الحاجه دي اسمها التروبيزم. بعد يحصل الاتاشمنت الخطوه اللي بعديها بيحصل شنو؟ فيوجن. الفيوجن بيحصل بشنو؟ بالجلايكوبروتين 41. يبقى الحاجات اللي بتهمنا دي هنا شنو؟ بيهمنا البروتيز وده حاجه يكسر لي البروتين بعدين. بيهمنا الريفيرس ترانسكريبتيز وبيهمنا الانتجريز. دي في اللايف سايكل الحاجات دي هتوضح. وبيهمنا البي 24 والجلايكوبروتين 120 121 والجلايكوبروتين 41. الاول 120 ده فور اتاشمنت والثاني فور انتري. طيب لحد هنا نحن في الاستراكشر عرفنا انه شنو؟ انه البتاع ده ار ان اي فيروس بوزيتيف سينس فيروس. جميل. والمود اوف ترانسميشن برنترال. ليه؟ لانه زي ما قلنا هو انفلوب فيروس. ممكن نمشي السلايد اللي بعديها. طيب السلايد اللي بعديها عايزين نتكلم عن ال HIV لايف سايكل اند كلينيكال امبورتنس. طيب اللايف سايكل بتاعت الفيروس هي بتشبه بعض كلها. اللي هي بتبدا بشنو؟ نمره واحد ريكوجنيشن اللي هي التروبيزم. يعني الفيروس ريكوجنايز سبيسيفيك سيلز. دي الخطوه الاولى. ومعاها في نفس الوقت في ناس بيعتبروها خطوه واحده اللي هي الاتاشمنت. يبقى الريكوجنيشن اند اتاشمنت ذيس ذا فيرست ستيب. الخطوه الاولى بيحصل اتاشمنت للفيروس. الفيروس بعد شويه بيحصل له شنو؟ انتري. اول ما يدخل السيتوبلازم بيحصل له حاجه اسمها انكوتنج. انكوتنج بيتخلص من شنو؟ بيتخلص بعد ذاك بيحصل ريموفال للانفلوب والكابسيد وهيقوم يديني شنو؟ يديني جينوم. طيب الجينوم بيحصل له ريبليكيشن. الريبليكيشن بيديني a lot of جينوم و a lot of بروتين اللي هي هتحصل الحاجه بتاعت السنترال دوجما اللي عارفينها زمان اللي هي دي ان اي ار ان اي اند بروتين. الخطوه الاخيره دي جنرال لايف سايكل دي ما خاصه بالاتش اي في. الخطوه الاخيره بيحصل حاجه اسمها شنو؟ السيمبولين. اللي هو نحن بدينا صنعنا قطع. صنعنا دي ان اي وار ان اي والانزيم اللي عايزينها والبروتين البرايم بروتين حقتنا اللي هو الار ان اي بروتيز هو ذاته عباره عن بروتين. دي بسموها برايم بروتين. وفي نفس الوقت عملنا سنسز للكابسيد اللي هو بروتين. الحاجات دي كلها على بعض بنسميها ريبليكيشن. حصل ريبليكيشن بعد ذاك الخطوه اللي بعدها بيحصل اسيمبلينج. اسيمبلينج بيحصل تجميع للاجزاء دي. يعني الجينوم يتغطى بكابسيد وبعد ذاك بيحصل ريليز. الريليز ده عندنا تو ميثود. اذا كان الفيروس نيجد سيل نيجد فيروس يعني ما عايز الانفلوب ما عايز السيل ممبرين في حاجه. هنا الريليز بيحصل باي رابشر اوف سيلز. ليه؟ لانه هو محتاج للسيلز. خلاص عمل الجينوم ماتيريال وكفر باي كابسيد كده بقى نيكد فيروس. طوالي هيمشي يعمل ليه شنو؟ رابشر للسيل وبعد ذاك يمشي انفيد النذر سيل. دي جنرال لايف سايكل. لكن الفيروس لو كان انفلوب لما نيجي في السيل ممبرين هيطلع بحاجه اسمها شنو؟ بروسيس اسمها بودنج. بيعمل حاجه كده بتاع التبرعم وبغطي نفسه بجزء من السيل ممبرين وبيطلع وبيريزيرف السيل ممبرين. لكن الحاجه دي لما تحصل كثير برضه شنو ايفينشولي بيحصل شنو رابتشر للسيل، لكن ما فروم ذا ستارت، زي اللي هي المساله بتاعت النيك فيروس. طيب نجي اللي هي اللايف سايكل بتاعتنا بتاعت الاتش اي في، نقولها تاني. الخطوه الاولى اللايف سايكل دي مهمه. طيب نستفيد شنو من اللايف سايكل؟ اللايف سايكل هنا في الاتش اي في يعني بتورينا حاجتين. الحاجه الاولى اللي هي ميكانيزم اوف انتي فيروس اي ار تي، بيحصل كيف؟ احنا لما نعرف اي ستيب كده فهمنا شنو اللي هي الميكانيزم اوف انتي فيروس. الحاجه الثانيه اللي بتحصل هنا بيورينا ليه انه اللي هي شنو لايف لونج ريزيرفوار. من اللايف سايكل هنطلع من النقطتين دي. طيب ممكن نمشي الخطوه الاولى بعد السلايد اللي بعديها. لا، السلايد الاولى اللي هي المكتوب فيها انتري انتو سيلز، قبل دي. ايوه، ايوه السلايد الاولى. تمام. يبقى جينا يا جماعه، جينا اتكلمنا عن اللايف سايكل، قلنا الخطوه الاولى بيحصل اتاشمنت. الاتاشمنت هنا بيحصل شنو؟ بيكون عندي اول حاجه بيحصل انتر اكشن بين الجلايكوبروتين الاول اللي شفناه ذاك، الجلايكوبروتين 120 بيحصل له اتاشمنت للسي دي 4. السي دي 4 ده اللي هو موجود مين اللي قلنا في شنو؟ في التي سيلز اند ماكروفيج، هتكلم عنها كويس السيلز دي، بس نخليها كده. نمشي للسي دي 4 سيلز، بيحصل انتر اكشن بين الجلايكوبروتين 120 in the presence of co-receptor. ودي بعدين هتفسر لنا، ممكن نقول هنا طوالي معانا. يبقى عندنا الانتراكشن بيحصل بين شنو؟ جلايكوبروتين 120 مع شنو؟ مع السي دي 4 الموجود وين؟ في الاوتر سيرفيس اوف ذا تي هيلبر سيلز اند ماكروفيج in the presence of co-receptor CCR5 or CXCR4. طيب انا هتكلم عن السي سي ار 5 الكوريسبتور. الكوريسبتور ده دايما بتلاقي في الخلايا بتاعت، اللهم صل وسلم على حبيب محمد، بتلاقي دايما في الماكروفيج وفي الدندريتك سيلز. طيب الاهميه بتاعته شنو؟ الاهميه بتاعته عندها الكلينيكال فاليو واضحه، اللي هو مارافيروك بلوك. ممكن هنا من الانتي فيروس يبدا يشتغل في الخطوه دي، يكفي اللي هو شنو؟ السي سي ار 5 دي اللي هي واحد ظهر لي هنا الميكانيزم بتاع الاي ار تي. الحاجه الثانيه، في ناس عندهم ميوتيشن في الكو ريسبتور ده زي الهيشين، اللي هو الناس اللي قاعدين في الجزر بتاع هايتي دي. الناس دي الاتش اي في بوزيتيف، لكن they will never develop AIDS. هم 6 وركر. لاحظوا انه الناس دي عندهم مشكله في الميوتيشن ده، بالتالي الفيروس بيكون موجود لكن ما بيتحول ليه لشنو؟ لايدز في الغالب. وهم حيكون في الحاله دي سورس اوف انفكشن اللي هو السي سي ار 5. يبقى السي سي ار 5 زي ما قلنا شنو موجود في وين؟ في الميل اللي في الماكروفيج. والسي سي اكس 4 ميل اللي بنلقاه في التي هيلبر سيلز. طيب السي سي ار 5 ده بنلقاه في الدندريتك سيلز. الدندريتك سيلز دايما بتكون قاعده وين؟ في الميوكس. ده بيساعد لي في السكشوال ترانسميتد ديزيز. يبقى في السكشوال ترانسميتد ديزيز الدندريتك سيلز قاعده وين؟ قاعده في الميوكس. بعد ذاك ممكن تشيل الفيروس وتوديه الليمف نود. زي ما عارفين السيمين فيه شنو؟ فيه ميوكس ممبرين، فيه ميوكس سبستانس. وهناك ممكن تلقى شنو؟ حوالين الفاجينا ممكن تلقى في الاريا دي برضه في شنو؟ في ميوكس ممبرين واضح، تلقى فيه دندريتك سيلز. ثرو السي سي ار 5 الفيروس بيدخل، ومن هنا بيمشي الليمف نود. والكلام ده هيوضح قدام. يبقى الخطوه الاولى نختصر الكلام ده يا شباب. طيب عندنا الخطوه الاولى الاتاشمنت، نقول الكلام ببساطه شديده. الاتاشمنت اللي هي انتر اكشن بين جلايكوبروتين 121 والسي دي 4 in the presence of CCR or CXCR as co-receptor. This is step 1. لو في اي زول عنده مداخله انا مستعد طوالي، انا ما عندي مانع انه المداخلات تكون اول باول، ما بالشرط في الاخر. اذا في زول عنده سؤال طوال يسال. طيب دي الخطوه الاولى. طيب بعد الخطوه الاولى حصل التاشمين. زي ما قلنا الخطوه الاولى هي صراحه هنا ما موضحه شديد، بتوضح الكلينيكال فاليو. طيب بعدها طوال عشان يحصل الانتري، اللي يحصل الانتري بيحصل بالجلايكوبروتين كم؟ 41. كده الفيروس دخل جوا. بعد يدخل الفيروس جوا الخطوه الثانيه هنا ما حتلقاها واضحه في اللايف سايكل، اللي هي هيحصل ان كوتنج. ان كوتنج هيحصل ريموفال لشنو؟ للاوتر لاير اللي هي الانفلوب، وفي نفس الوقت الكبسيد، ويحصل ريليز للجينوم. الجينوم بتاعنا هو عباره عن شنو؟ هو عباره عن RNA deployed two segment of RNA، ومعاها شنو؟ معاها ريفيرس بروتين جاهز، ريفيرس ترانسكريبتيز. طيب الريفيرس ترانسكريبتيز ده هيعمل لي شنو؟ هيحول لي الار ان اي فيروس، لانه
Sadig, we lost you for a minute. Hello? صادق ممكن تواصل؟
ار ان اي يتحول لدي ان اي. طيب الدي ان اي قبيل في الاستراكشر عندنا اللي هي انزيم اسمه انتجريز، هيشيل الار ان اي ده من السيتوبلازم، هيتحصل في السيتوبلازم ويمشي يعمل له انسيرشن وين؟ في الدي ان اي انسايد نيوكليوس. يبقى الحاجه دي اسمها انتجريز. يبقى الدي ان اي دخل وين؟ في التي هيلبر سيلز اور الماكروفيج. الماكروفيج طبعا عمره اطول من التي هيلبر سيلز. وهنا دي الحته اللي بنتكلم عن فيها شنو؟ اللي هي في الحاله دي الهيومن بيتحول لشنو؟ للايف لونج ريزرفوار. ليه؟ لانه حيمشي يحصل له ليتنسي، حيمشي ينوم هناك وين؟ في اللي هي inside nucleus of macrophage and T helper cells. يبقى حتى الان عندنا بقى عندنا شنو؟ دي ان اي قاعد وين؟ هناك. مجرد ما يحصل انفكشن هيمشي، ودي الفتره دي مرات بيحصل فيها بعد الفتره دي بيحصل ليتنسي، ودي ممكن تاخذ فتره طويله جدا. مجرد ما يحصل استيميوليشن للاميون سيستم وتبدا السيلز دي ريبليكيت، هنا طوال الدي ان اي ده هيديني شنو؟ هيديني ار ان اي، والار ان اي هيديني شنو؟ بروتين. بعد ذاك الخطوه اللي بعديها طوال هنتكلم عنها اللي هي شنو؟ الانتجريز. كده امشي الخطوه اللي بعديها على الانتجريز يا دكتوره. ايوه الانتجريشن تكلمنا عنها واضحه. يبقى الخطوه الاولى من ار ان اي حولناه لدي ان اي، وجينا ربطناه بالانتجريشن اللي هي انتجريز. امشي قدام شويه اهي. كده عملنا انتجريشن، والانتجريشن ده زي ما قلنا ده شنو؟ ده اكسبلين اللايف لونج انفكشن. وهنا يعني عند المقطع الاخير ده دايما تلقاه كلمه جرافير، اللي هو تولت جرافير، رالت جرافير، كلها بنلقاها ماشيه بشنو؟ بالجرافير. اللي هي دي شنو؟ دي الانتجريز. بعد الانتجريز الخطوه اللي بعديها زي ما قلنا شنو؟ بيحصل ريبليكيشن عادي اللي هي نفس السنترال دوجما زمان دي، دي ان اي، ار ان اي، ان بروتين. طيب بعد ذاك بيحصل شنو؟ نجي بالنسبه للاتش اي في، هنا حيكون عندي شنو؟ ار ان اي صنعناه من الاول، كفر باي كابسيد. وبعد الكابسيد حيمشي شيء شنو؟ هو طالع حيطلع بالبضن. وهناك بعد ذاك لحد اللحظه دي الفيروس بتكون شنو؟ اماتيور. ليه؟ لانه البروتين الجوا المصنع ده بيكون عباره عن بولي بروتين، والبولي بروتين ان اكتف. لو متذكرين زمان في حاجه اسمها شنو؟ بوست ترانسليشن، اللي هي موديفيكيشن، نحول من بروتين ان اكتف لبروتين اكتف. ودي بيعمل لي شنو؟ البروتييز. يبقى هو بيصنع لي البروتين از 1 سيجمنت طويله ان اكتف. بعدها بيجي البروتييز يقطع عليه لشنو؟ لاكتف سيجمنت. يبقى هنا دي شنو؟ دي البروتييز انهيبيتر بتشتغل في الحته دي. طيب لو ما في بروتييز انهيبيتر الفيروس حيكون مكتمل لكن شنو؟ ان اكتف. ليه؟ لانه جوا البروتين بتاعه عباره عن شنو؟ عباره عن بولي بروتين، يعني very long segment of inactive protein activated by protease. ودي هنا زي مشهوره طبعا، انا ما بديت هنا، ما في اكزامبل واضح هيظهر قدام زي الريتونا فير وغيرها. تلقاه دايما منتهي بمقطع نافير. طيب دي ريبليكيشن. اخر حاجه زي ما قلنا الخطوه اللي بعدين اللي هي شنو؟ assembling and بادنج. طيب قال لك فيروس اسامبل ات سيلز، بعد ذاك زي ما قلنا بيحصل بادنج بيطلع برا. تقريبا اللايف سايكل ما في حاجه. نطلع شنو من اللايف سايكل؟ انه اللي هي المساله بتاعت الريفيرس ترانسكريبتيز. عرفنا ليه عمل ريفيرس ترانسكريبتيز في حين انه كان ايزلي من الار ان اي يمشي للبروتين، لانه عايز يعمل دي ان اي، والدي ان اي يحصل له انتجريشن انسايد هيومن سيلز ويقوم يديني شنو؟ لايف لونج ريزيرفوار. دي البوينت الاولى من اللايف سايكل. البوينت الثانيه اللي هي على حسب، في الانتري عندي انتي فيروس، وفي الريبليكيشن، وفي الانتجريشن، وفي الريفيرس ترانسكريبتيز. هي دي بتوضح لي شيء. لحد هنا بنكون فهمنا الميكانيزم اوف فيروس. طيب النقطه اللي بعديها، طيب اتش اي في immunology. قبل ما نخش جوا ده نتكلم شويه عن السيلز. طيب نحن لما نيجي نعمل سي بي سي عندنا الوايت بلس سيلز بنقسمها لتو جروب. معلش انا هبدا من البدايه. الليفل ده المتعودين نشتغل بهم مع الميديكال ستودنت، وهنا ما شاء الله الناس جاهزين، لكن بس نبدا القصه من البدايه. طيب عندنا السيلز بنقسمها لجرانيولوسايت، اللي هي دي فيها شنو؟ دي هنا ما حتشتغل معانا، ما حتحصر لنا، لانه إحنا عندنا الاميون سيستم بتكون من ادابتيف سيلز وانيت سيلز. حتصير لك سيلز كثيره بالراحه، انا حاشرح الحته دي. طيب عندنا جرانيولوسايت اللي هي دي زول بيعرفها، النيوتروفيل الايزينوفيل البيزوفيل، هنا ما داخله معانا بشكل واضح. وعندنا بيجي الاي جرانيولوسايت. الاي جرانيولوسايت دي اللي هي شنو؟ دي سيلز اوف ادابتيف اميونيتي، اللي هم عباره عن جاست تو سيلز. منو؟ ليمفوسايت اند مونوسايت. طيب هتسمع بعد شويه دندريتك سيلز ومايكروجليال سيلز وكفر سيلز، كلام كثير، لكن الموضوع سهل، فاين اند ايزي. يبقى عندنا الادابتيف سيلز هم تو سيلز اللي هم منو؟ ليمفوسايت and monocyte, just two cells. طيب الليمفوسايت فيها منو؟ فيها التي سيلز، وهم تو تايبس اللي هم التي هيلبر سيلز والسايتوكسيك تي سيلز. انا طبعا قاعد اقول حاجه الظاهر اللي بتلاقينا في اللايف سايكل. يبقى دي الليمفوسايت عندنا فيها اللي هي التي سيلز، التي هيلبر سيلز، واسمها الثاني السي دي 4. التي هيلبر سيلز اسمها السي دي 4 لانه في الاوتر ممبرين بتاع التي هيلبر في السي دي 4. وعندنا السايتوكسيك تي ليمفوسايت، وفي الاوتر سيرفيس عندها سي دي 8. يبقى التي سيلز فيها التي هيلبر 4 هيلب اللي هي ده النيمونيك البسيط، 4 هيلب اللي هي سي دي 4، وسي دي 8 اللي هي دي سايتوكسيك تي سيلز. وعندنا الليمفوسايت لما يحصل لها ماتوريشن بتدينا شنو؟ البلازما سيلز، والبلازما سيلز عارفينها بتطلع الانتي بوديز. دي الليمفوسايت كده ما عندنا كلام ده نقوله فيها. في خليه ثالثه في الليمفوسايت، مع انها ليمفوسايت لكن هي عباره عن شنو؟ عباره عن innate cells not adaptive cells، اللي هي دي يسموه دي اللي هي شنو؟ اسمها الناتشورال كيلر. الناتشورال كيلر دي عباره عن لارج جرانيولار ليمفوسايت، ما بتلقاها في السي بي سي. هي ليمفوسايت لارج جرانيولار. انا حاجي اقول الكلام ده بالراحه حشرح، ده اشرح الحاجات دي واحده واحده. لارج جرانيولار سيلز وظيفتها شنو؟ بعدين لما نجي في الفيروس، الفيروس عندنا حاجه اسمها السي دي 8 في السيتوكسيك سيلز، بتفاعل مع الميجر هيستو كومباتيبيليتي في الفيرال انفكتد سيلز. لو لقى البروتين اللي في الميجر هيستو كومباتيبيليتي ده اب نورمال بروتين، يعني بروتين بروديوس باي فيروس اور تيومر سيلز، السيتوكسيك هنا بتقتل ليه شنو؟ كيل فيرالي انفكتد سيل. طيب مرات الفيروس بيقوم يعمل حركه، يقوم الميجر هيستو كومباتيبيلتي كلاس 1 اللي بيتعرض فيه البروتين من جوا يقوم يقفله، عشان لما تيجي سايتوكسيك تيلز تعمل انتر اكشن اللي هي سي دي 8 مع الميجر هيستو كومباتيبيلتي كلاس 1 ما تلقى اصلا ميجر هيستو كومباتيبيلتي كلاس 1. في الحاله دي السي دي 8 ما حتقتل الفيرال انفكتد سيل. هنا حتظهر خليه اسمها الناتشورال كيلر. الناتشورال كيلر دي عندها وظيفه واحده، اي خليه do not express major histocompatibility class 1 killed by natural killer، عشان اذا لقيتك قدام تكون الفكره واضحه. طيب نرجع تاني للسيلز بتاعتنا. قلنا الادابتيف سيلز هم تو سيلز اللي هو الليمفوسايت ومونوسايت. الليمفوسايت فيها بي سيلز وتي سيلز، انتهينا منها. طيب الحته دي الثانيه شويه دايره تركيز. طيب المونوسايت في البلاد ستريم اسمها مونوسايت، لو حصل لها ترانس مايجريشن مسكت التشو بيبقى اسمها شنو؟ ماكروفيج. الكلام ده حنقوله ليه؟ لانه حنتكلم عن السيل ميديتد اميونيتي والهيومرال، والاسماء دي حتظهر. يبقى المونوسايت هي ذاتها لما يحصل لها ترانس مايجريشن وتتحرك من البلد ستريم للتشو بيبقى اسمها ماكروفيج. دي الخليه الاولى. يبقى مونوسايت هي عباره عن شنو؟ جاست ترانس مايجريتوري ماكروفيج. طيب، عندنا حاجه ثانيه اسمها الريزيدنس ماكروفيج. لما هي المونوسايت حصل لها ترانس يعني حصل انفكشن، المونوسايت قاعده في البلاد ستريم، طلعت من البلاد ستريم مشت التشو بنسميها ماكروفيج. مرات نحن ما بكون عندنا زمن، محتاجين خلايا تكون ريزيدنس قاعده، ما بتجي اون كول. الريزيدنس دي عندها ديفرنت نيم. يبقى هي نفس الماكروفيج لو كانت في الليفر سيلز اسمها الكوفر سيلز، وهكذا. ولو في البرين اسمها المايكروجليال سيلز، ولو كانت في الميوكس في
Hello, دكتور صادق. صادق. Hello. Sadig, we lost connection for a minute. Hello.
معلش قطع ولا شنو؟
أيوة كده رجعنا تمام.
طيب نحن واقفين وين؟ اخر كلمه قلنا شنو؟ شكله كان قاطع، ما كنت بتابع انتهت
وقفنا
خلاص.
في الحتة بتاعت الماكروفاجز.
طيب نقولها سريع، نختصرها سريع. عندنا السيلز اوف ادابتيف اثنين، ليمفوسايت بانواعها المختلفه، بي سيلز وتي سيلز. وعندنا المونوسايت، دي اللي هي شنو في البلاد ستريم، لو حصل لها ترانس مايجريشن يبقى اسمها ماكروفيج. لو بقت اصلا ريزيدنس قاعده في حتات معينه تيك ديفرنت نيم على حسب. يبقى في الليفر كوفر سيلز، في الليمف نود، وفي الميوكس ممبرين اسمها دندريتك سيلز، وفي البرين اسمها مايكروجليال سيلز، وفي السكين اسمها لانج هانس سيلز. الكلام ده عايزين نقوله ليه؟ لانه عايزين نمشي للسلايد البعديه اللي هي فيها شنو. طيب اول سلايد لو سمحت يا دكتوره زلال، السلايد اللي فيها الدايفرام بعد الاميونولوجي دي. طيب يلا، دي اهم سلايد. نحن هسه قلنا الكلام ده جبال. عندنا ثاني حاجه اسمها رول اوف 8. رول اوف 8 دي اللي هي شنو؟ اللي هي سي دي 4 interact with major histocompatibility class 2. يعني بنقول كده 1 في 8 اللي هي شنو يساوي 8. يعني الميجر histocompatibility class 1 interact with سي دي 8 الموجود في سايتوكسيك تي ليمفوسايت. والميجر هيستوكومباتيبيليتي كلاس 2 انتراكت وذ اللي هو شنو السي دي 4. طيب الكلام ده هنجي يشرح لنا ببساطه اللي هي مساله الهيومرال اميونيتي. فيها تو بار، فيها سيل ميدييتد اميونيتي، وفيها الجزء الثاني اللي هي الهيومرال. طيب هنبدا واحده واحده. طيب هنبدا بالسيل ميدييتد اميونيتي. الخطوه الاولى نحن هنكون في نفس السلايد دي، الصوره ما واضحه شديد لكن ممكن نشوف الجزء ده. طيب دقيقه. طيب نمسك الجزء اليمين، الصيد اليمين. يبقى في الاول اول خليه فوق يعني عندي الفيروس، اللي هي نحن بنقسم الاورجانيزم لانترا سيلولر اورجانيزم واكسترا سيلولر اورجانيزم. طيب الانترا سيلولر اورجانيزم بنشتغل عليها بالسيل ميديتد اميونيتي، والاكسترا سيلولر اورجانيزم بنشتغل عليها بالهيومرال اميونيتي اللي هي انتي بودي ميديتد. طيب، نمسك الجزء الاول اللي هي مثلا عندنا الفيروس. الفيروس ده انجلب باي ماكروفيج، وهنا اسمها شنو؟ اسمها انتيجين بريزنتنج سيلز. وفي الاوتر سيرفيس بتاعها عندها شنو؟ عندها الميجر هيستو كومباتيبيليتي كلاس 2. يبقى عندي الان ماكروفيج، اسمها الثاني انتيجين بريزنتنج سيل. ليه؟ لانها بريزنت سبيسيفيك بارت اوف فيروس تو انذر سيلز. انذر سيلز دي تي هيلبر. يبقى الماكروفيج عملت انجلف للفيروس، عملت له ديجراديشن، وشالت سمول بارت من شنو؟ من البروتين بتاعت الفيروس، واكسبوز اون ميجر هيستو كومباتيبيليتي كلاس 2. يبقى حتى الخطوه دي عندي شنو؟ عندي ماكروفيج في الاوتر سيرفيس عليها ميجر هيستو كومباتيبيليتي كلاس 2، شايل شنو؟ بارت اوف فيروس. الحاجه دي ماشيه تقدمها لشنو؟ للتي هيلبر سيلز، عشان كده سموها انتيجين بريزنتنج سيلز. يبقى هتمشي هناك الميجر هيستو كومباتيبيليتي كلاس 2 مع التي هيلبر مع السي دي 4، هيحصل انتر اكشن، يحصل برزنتيشن للانتيجين ده. تقوم التي هيلبر سيلز يحصل لها ديفرنشيشن انتو تي هيلبر 2 ذاتها، من تي هيلبر 0 تبقى 2 هيلبر 2. التي هيلبر 2 ده حط لي كميه من السيتوكاينز ما عايز اتكلم عنها. الفكره بتاعتها تمشي شنو؟ تمشي للبي سيلز. البي سيلز هيحصل لها ماتوريشن، هتبقى بلازما سيلز، والبلازما سيلز حط لي شنو؟ الانتي بوديز. يبقى نقولها تاني، يبقى انتر اكشن بتوين ماكروفيج and T helper zero through what? Through CD4 and major histocompatibility class 2. طيب then T helper 0 become T helper 2 which secrete interleukins. a lot of interleukin ما ده نخش في التفاصيل. الحاجه دي مش تعمل لي اكتيفيشن للبي سيلز، والبي سيلز تبقى بلازما سيلز، والبلازما سيلز بروديوس انتي بوديز. يبقى ده الهيومرال بارت الاول. تمام. الجزء الثاني نفس الخطوه بتحصل، اللي هي لكن هنا الاورجانيزم بيكون شنو؟ اكسترا سيلولر. هنا في الفيروس اكسترا سيلولر قاصدين شنو؟ قاصدين الجلايكوبروتين 121 اللي قاعد في الاوتر سيرفيس. الجسم بيتعامل معاه كحاجه زي شنو؟ زي الاكسترا سيلولر، لانه قاعد في الاوتر سيرفيس. بعد يحصل ريليز من الفيروس، هو حيكون زيه زي اي بكتيريا، حيكون في الاوتر سيرفيس. يبقى ده هنا ده الانتيجين بتاعنا القاصدينه. وهنا اكت از شنو؟ لا 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 لا، ده في الانتي بوديز. يبقى الانتي بوديز دايما طلعناها عشان نرجع تاني. طيب قلنا ماكروفيج، تي هيلبر 0، تي هيلبر 2، بي سيلز، انتي بوديز. الانتي بوديز دي اجينست شنو؟ اجينست الجلايكوبروتين 120، ده الجزء الاول. اجينست تو سام اكستنت الجلايكوبروتين 41، ده الجزء بتاع الهيومرال بارت. طيب الجزء الثاني اللي هي هنا عندي شنو؟ عندي فيرالي انفكتد سيلز. يعني الفيروس قاعد وين؟ انسايد سيلز. في الحاله دي انا حاجته له كيف؟ صعب، الانتي بوديز ما هيشتغل. هيشتغل بحاجه اسمها سيل ميديتد اميونيتي. يعني شنو سيل ميديتد؟ يعني سيلز كيل انذر سيلز. ده بيحصل كيف؟ ماكروفيج شايله شنو؟ اللي هي انترا سيلولر اورجانيزم، حصل لها انتر اكشن مع التي هيلبر 0. التي هيلبر 0 هتبقى تي هيلبر 1. التي هيلبر 1 هتمشي تعمل لي اكتيفيشن للسيتوكسيك تي ليمفوسايد، والسيتوكسيك تي ليمفوسايد كيل فيرالي انفكتد سيلز اور تيومر سيل. ثرو شنو بتقتلها؟ ما هي قلنا عندها هي سي دي 8. معلش الدايفرام بس ما واضح. هي الخليه دي عباره عن السيتوكسيك تي ليمفوسايد مع الفيرال انفكتد سيل. الانتر اكشن بيحصل بشنو؟ سايتوتوكسيك عندها سي دي 8، هيمشي يتفاعل مع الميجر هيستوكومباتيبيليتي الموجود مع الفيرال انفكتد سيلز او التيومر، وبعد ذاك بحاجه اسمها بيرفورين اند جرانزايمز اللي هو بيحصل لايس للسيلز. يبقى ده نقول شنو الخلاصه بتاعت الكلام ده. لو لاحظت الكي بلاير في الهيومرال، الخلاصه خالص دايما بتبدا بماكروفيج وبعد التي هيلبر. التي هيلبر دي يا بيجت 1 عملت لي اكتيفيشن للسيل ميديت اميونيتي، يا بيجت 2 عملت لي اكتيفيشن للهيومرال. طيب الفيروس هنا الاتش اي في بيضرب شنو؟ بيضرب الماكروفيج. نمره واحد. وبيضرب التي سيلز، يبقى حصل لي بلوكج لشنو؟ للتو باث واي. وده الباثوجينيسيس بتاع الاتش اي في. دي الفكره، انه بيضرب الماكروفيج الخليه الاولى، وبيضرب التي هيلبر الخليه الثانيه اللي هي شنو؟ حسب الاكتيفيشن. لو بقت تي هيلبر 2 هتمشي هيومرال بارت، لو بقت تي هيلبر 1 هتمشي سيل ميديتد بارت. يبقى نحن قفلنا ستيب 1 وستيب 2، بالتالي عملنا شنو؟ قفلنا كل الباث واي بتاع السيل ميديتد اميونيتي والهيومرال اميونيتي. وده الفيروس بيشتغل في الخلايا دي. طيب، نمشي قدام شويه بعدها. طيب، دي هنا هنلخصها تاني بنفس الكلام اللي قلناه ده، هنلخصه سريع. عندنا الماكروفيج، جميل، واللي هي انتيجين بريزنتنج سيلز. وعندها الميجر هيستو كومباتيبيليتي، مشت عملت لي اكتيفيشن للنايف تي سيلز اللي هي دي لونها اصفر دي، وهي ذاتها بقت تي هيلبر سيلز. والتي هيلبر سيلز طلعت لي حاجه اسمها انترفيرون جاما، وانتر اللي هي انترليوكين 2. ومشوا عملوا لي شنو؟ اكتيفيشن للسايتوكسيك تي سيلز، وكيل الفيرالي انفكتد سيلز. اقلب للسلايد اللي بعديها. نيكست سلايد. يلا، زي ما قلنا عشان ما انتوا، ماكروفيج، جميل، اكتيفيت تي هيلبر 0 and become T helper 1. T helper 1 activates cytotoxic T cells. Cytotoxic T cells kill virally infected cells or tumor cells. ده الباسوي بتاع السيل ميديت اميونيتي. بعده، طيب ايوه، ممكن نجي في النقطه دي، هتكلم عنها شويه، لانه ده بيوريك الاسوسيشن بين التي بي and اتش اي في. نحن قلنا الماكروفيج اكتيفيت التي هيلبر 0، والتي هيلبر 0 بتبقى تو هيلبر 1 وتمشي تعمل سايت توكسيك. لا، هنا الباث واي ده بقى هيرجع، هيكون الباث واي كيف؟ هيكون ماكروفيج اكتيفيت تي هيلبر 0، وهتبقى تي هيلبر 1، والتي هيلبر 1 تمشي تعمل لي شنو؟ ري اكتيفيشن للماكروفيج. يبقى الماكروفاج دي اصلا هي اكتيف سيلز، لكن حصل لها شنو؟ ري اكتيفيشن. يبقى ده عباره عن اكزاجريتد ريسبونس. بما انه اكزاجريتد ريسبونس، يبقى ده الهايبر سنسيتيفيتي، ودي الهايبر سنسيتيفيتي تايب 4 اللي بتشتغل في التيوبركلوزيس. والري اكتيفيشن من التي هيلبر 2 للماكروفاج بيتم بالانترفيرون جاما. ودي عملوا فيها التيست بتاعت الاجرا اللي هي ذات الانترفيرون جاما بتاعت التيوبركلوز. يبقى الباثوي ده برضه قفل. والباثوي ده اللي بيعمل ليه شنو؟ كيلينج ليه شنو؟ ده اللي بيعمل الجرانيولوما. يعني الماكروفيج تي هيلبر 0، تي هيلبر 2، ري اكتيفيت ماكروفيج. السايكل الصغيره اللي بالجنب دي عباره عن الهايبر سنسيتيفيتي تايب 4 اللي هي بتشتغل لي في شنو؟ في الباثوجينيسيس بتاعت الجرانيولوم بتاع التيوبركلوز. يبقى دي هنا اتضربت. عشان كده من البدايه بنلقى في اسوشيشن بين شنو؟ اتش اي في اند تيوبركلوزس، وعملوا منها الاجرا. نمشي بعدها طوالي للاكسترا سيلولر اورجانيزم. طيب، الاكسترا سيلولر نقولها تاني. عندنا الماكروفيج اللي هي انتيجين بريزنتنج سيلز، انتر اكت عنده الالوان اللي هي الماكروفيج لونه اصفر، انتيجين بريزنتنج سيلز which activate naive T helper cells and become T helper 2. T helper 2 زي ما قلنا شنو؟ activate B cells which proliferate to اللي هي بلازما سيلز which produce antibodies. ده الباثوي ملخص تاني. والانتيبوديز عارفين انها بتعمل شنو؟ بتعمل نيوتراليزيشن. اللي هي النيوتراليزيشن دي عباره عن شنو؟ يعني يمشي الانتيبوديز، يمشي يربط لي مع وين؟ مع الجلايكوبروتين 120 اللي قاعد في الاوتر سيرفيس. بالتالي قفلت شنو؟ الاتاشمنت. واوبسونايزيشن اللي هي دي الفكره شنو بتاعت الاوبسونايزيشن. اوبسونايزيشن بيحصل الانتي بودي يمشي يربط هناك، يقوم يحصل اللي هي الحاجه دي بتكون شنو؟ ريدي فور فاجوسايتوزيس. يعني الفيروس بيطلع. الخطوه الاولى نيوتراليزيشن، انه جاست انتر اكشن بين الانتي بوديز والجلايكوبروتين 120. دي الخطوه الاولى. الخطوه الثانيه، الحاجه اللي بقت ماركر اوبسونايزيشن، يعني هي بنقول باختصار هي ريدي تو فاجوسايتوز. مجرد ما تجي الماكروفيج ماشيه، تلقى في انتي بوديز رابط مع اي حاجه، طوالي بتعمل له انجلف. الحاجه دي اسمها اوبسونايزيشن. وفي طريقه ثانيه اللي هو حتى لو ما حصل له انجلف، يحصل انتيجين انتي بودي رياكشن، والانتيجين انتي بودي رياكشن اللي هي بيعمل اكتيفيشن للكومبلمنت. يبقى في النهايه دي تفاصيل صغيرون. بعده، طيب، تاني ما في كلام كتير عايزين نقوله. عندنا هنا حاجه اسمها شنو الهوست سيل تارجت، زي ما قلنا الخلايا بتاعتنا اللي هي السي دي 4 التي هيلبر والماكروفيج والدندريتك سيل، هي عباره عن شنو؟ جست اللي هي شنو ريزيدنس ماكروفيج، الخلايا المصابه. يبقى هم التو سيلز اللي بيصيبون، بيصيب ليه التي سيلز زي ما الكلام بقى واضح، ومعانا شنو الماكروفيج. طيب، وعندنا حاجه اسمها شنو السي دي 4 والكوريسبتور. الكوريسبتور زي ما قلنا الاول اسمه سي سي ار 5، ده بيحصل ليه في الايرلي انفكشن. والسي اكس سي ار ايرلي انفكشن قاصد بها شنو؟ يعني لما يكون الفيروس وين مع الميوكس ممبرين، والميوكس ممبرين زي ما قلنا هتيجي تشيل اول خليه الدندريتك سيلز، والدندريتك سيل محتاجه لشنو؟ سي سي ار 5، دي اول خليه بتصاب. طيب، بعد ذاك مش يضرب التي سيلز اللي هي هناك الكو ريسبتور شنو؟ سي اكس سي ار، ودي اللي بيحصل فيها سي دي 4 كاونت سبريشن. زي ما عارفين ان هي الخلايا هيجي اللي قدام كان واضح. دي الفكره بتاعت ايرلي وريت. طيب، بعده اتش اي في تارجت سيلز اند كلينيكال سيجنيفيكانت، نفس الكلام ما في جديد. احنا عندنا هنا بيتكلم عن السي دي 4 اللي هو ده الريسبتور اللي بيضغط على ال 120. بعد ذاك يتكلم عن الارقام، قال النورمال بتاع السي دي 4 كاونت اللي هي من 500 ل 1500، 500 ل 1500. وفي ناس بيقول ايدز ديفينيشن اللي هي اقل من 200. واللوس اوف سي دي 4 بيعمل اميونو سبريشن، والاميونو سبريشن بيخلي البيشنت ات ريسك اوف اوبورتيونستيك انفكشن. ما في حاجه في السلايد اللي بعده. طيب، عندنا زي ما قلنا الماكروفيج اللي هي دي لونج ليف ريزرفوار، زي ما قلنا حتقعد فيها لفتره طويله جدا، وتكلمنا عنها قبل. ما في حاجه بنقولها هنا. وفي النقطه الاخيره قال لك اتش اي في اسوشيتد نيورو كوجنيتيف ديسوردرز، اللي هي سماها هاند، اللي هي المايكروجليال سيلز جوا انفكتد بالفيروس. والفيروس هيقوم يضرب لي اللي هي المايكروجليال سيلز اللي هي الماكروفيج اللي قاعده في البرين، يقوم يديني بحاجه اسمها شنو الاتش اي في بيرسي، يعمل لي حاجه اسمها اتش اي في انكفالوباسي. بعده دندريتك سيلز قال لك دي كابشر اتش اي في ات ميوكوزال سيرفيس، اتكلمنا عنها كويس. وترانسبورت الفيروس، هتقوم تشيل الفيروس من شنو؟ من الميوكوزا للليمف نود. عشان كده دايما بتلقى في الايرلي انفكشن بتلقى في ليمف ادينوباثي، ده بتعمله الدندريتك سيلز. وده قال لك important in sexual transmission of HIV. بعده جينا تاني اتكلمنا عن شنو؟ عن السي اللي هو الكوريسبتور سي سي ار 5. ما في كلام بيتقال، نفس الكلام اللي قلناه. اتكلمنا عن الانتي فيروس واتكلمنا عن التروبيزم. بعده، طيب، جينا اتكلمنا عن الاذر كوريسبتور، نفس الفكره اللي هو ده في التي هيلبر سيلز مينلي، وذاك في الماكروفيج اند دندريتك سيلز. ما في كلام تاني، نفس الكلام. بعده، طيب، نجي لحاجه اسمها اميون ايفيجن ميكانيزم، اللي هو الفيروس بيحصل له اسكيب كيف من الحاجه دي. وليه نحن برضه في سؤال المفروض نجاوبه قبل في اللايف سايكل، اللي هو ليه نحن بنستخدم مور ذان 1 انتي فيروس؟ طيب، بيحصل شنو؟ نمره واحد قال لك هاي ميوتيشن. شوف ال الانزيم الاول الريفيرس ترانسكريبتيز الاول اللي بيحول الار ان اي لدي ان اي، البتاع ده ما عنده بروف ريدنج. اللي هي نحن عندنا في الدي ان اي بعد تصنع الدي ان اي من الدي ان اي يتحول لار ان اي، في حاجه اسمها بروف ريدنج بيجي بيتقري وبيحصل كوركشن للميستيك ده او كيل، الحاجه دي يحصل لها ريموفال. هنا ما بتحصل الحاجه دي. ليه؟ بيكون بيحصل لي هاي ميوتيشن، بالتالي هاي ميوتيشن محتاج لشنو؟ للوت اوف انتي فيروس. اضرب في كم حته، لانه ممكن يكون عندها انتي فيروس بيشتغل في حته معينه يقوم يحصل. يبقى عندنا هنا دائما الفيروس. وشوف سبحان الله في الحاجه دي، يعني في الفيروس، يعني احنا بنقول في الفيروس عموما، يعني الفانكشنينج فيروس بيكون جاست 10%. يعني اذا صنعت 100 فيروس الشغالين منهم 10، ال 90 بيكون نون فانكشنينج، بيكون ميوتيتد. الاميون سيستم بيستفيد منها في شنو؟ في الحاجه دي انها جاست ستيميوليت الاميون سيستم، وهي بتكون شنو؟ نون اكتف، اكتف لايك فاكسين. وفي نفس الوقت هي بتساعد الفيروس في انه شنو؟ في انه الميوتيشن ده بيعمل له يخليه شنو؟ يعمل له ايفيشن اور اسكيب فروم الاميون سيستم. دي النقطه الاولى. النقطه الثانيه الانتجريشن. طبعا انت شلت الفيروس من السيتوبلازم ودخلت النيوكليوس، ده هيديني شنو؟ ليتنسي، لايف لونج ليتنسي. وعندنا حاجه اسمها النيف، اللي هي النيف دي عباره عن شنو؟ النيف ده جزء من الفيروس بيعمل لي داون ريجوليشن للميجر هيستو كومباتيبيليتي كلاس 1. طيب الميجر هيستو كومباتيبيليتي كلاس 1 ده شنو؟ شوف اي خليه فيها نيوكليوس معناتها فيها دي ان ايه، معناتها بتصنع بروتين. البروتين ده المفروض يتعرض وين؟ على الميجر هيستو كومباتيبيليتي كلاس 1. يعني الخطوه كالاتي: هي بتكون نيوكلييتد سيلز فيها دي ان ايه، الدي ان ايه بيتحول لار ان ايه، والار ان ايه بيتحول لبروتين. البروتين الانترنسيك بروتين المصنع ده عشان نعمل له تشيك المفروض يتعرض على الميجر هيستو كومباتيبيليتي كلاس 1. طيب الخليه الميجر هيستو كومباتيبيليتي كلاس 1 الموجود في كل الخلايا النيوكلييتد سيل اكسبت الار بي سيز بيكون شايل الانترنسيك بروتين which is synthesis by our machinery protein synthesis اللي هي الصنع جوا. يبقى عندنا دي ان ايه، ار ان ايه، بروتين. البروتين ده بيحصل له شنو؟ برزنتيشن وين؟ في الميجر هيستو كومباتيبيليتي في الاول نيوكلييتد سيل. طيب البروتين ده لو كان نورمال سيلز هتجي خليه اسمها سايتوكسيك تي ليمفوسايت شايل السي دي 8 زي ما قلنا رول 8. يبقى السي دي 8 مع الخليه النيوكلييتد سيل فيها ميجر هيستو كومباتيبيليتي، يبقى الميجر هيستو كومباتيبيليتي كلاس 1 انتر اكت مع السي دي 8 الموجود في السايتوكسيك تي سيلز. بتبدا تقرا البتاع ده اذا كان نورمال بروتين حقنا الخليه دي سيرفايف بتعيش. لكن البروتين ده لو كان فايرال بروتين او تيومر بروتين السيتوكسيك تي سيلز بتقتل الاب نورمال سيلز. يبقى بتجي السيتوكسيك تي سيلز شايله السي دي 8 انتر اكت مع الميجر هيستو كومباتيبيليتي كلاس 1 الموجود في نيوكلييتد سيلز. لو كان زيس اور بروتين سيرفايف، نوت طوالي كيل. طيب الفيروس بيقوم يعمل شنو؟ يقوم يعمل داون ريجوليشن للميجر هيستو كومباتيبيليتي. تقوم تجي سي دي 8 ما تلقى ميجر هيستو كومباتيبيليتي اصلا عشان تقراه، بتمشي. لكن زي ما قلنا عندنا هنا الجسم عمل حاجه ثانيه، جاب خليه اسمها الناتشورال كيلر. الناتشورال كيلر بتجي ماشيه بعد شنو؟ بعد السايتوكسيك. الخليه دي ما عندها ميجر هيستو كومباتيبيليتي، طوالي شود بي كيل. وده الميكانيزم اللي عمله الجسم واللي عمله الفيروس. الاخير اللي هي كرونيك اميون اكتيفيشن، زي ما قلنا البتاع ده بيحصل له ليتر في السيلز، ومجرد ما يحصل اميون ريسبونس هيحصل بروليفريشن لشنو؟ للتي سيلز، وتبدا تصنع البروتين وتصنع معاها الفيروس. يبقى كل ما يحصل انفكشن كل ما يحصل شنو؟ ريليز للفيروس. دي الفكره، ده اللي هو الاميون ايفيجن ميكانيزم. بعده
دكتور صادق، الفيزز اوف اتش اي في ان اكيوت فيز هتغطيها دكتورة نادية ان ديبث ان شاء الله، فنمشي فيها سريع.
طيب دي ما هتكلم عنها طوال، يلا امشي بعده. طيب امشي للدايجنوز اوفر فيو. طيب دايجنوز اوفر فيو اتكلمنا عن البي 24 اتكلمنا عنها كويس. طيب عندنا هنا حاجه اسمها الفورس جنريشن، امشي بعديه طوال الدايجنوز لاست وان. طيب اتش اي في دايجنوز طوال كله ده نفس الكلام معاد. بعد نيكست. طيب يلا يا جماعه الاتش اي في. طيب نحن عايزين نقول شنو في الاتش اي في دايجنوز. خليك في السلايد الاولى مكتوب فيها اتش اي في دايجنوز عشان هتكلم شويه بريف ونخش في الموضوع. طيب عندنا الاتش اي في دايجنوزز. نمره واحد عندنا كونفirmatory تيست. اول حاجه يو شود دايجنوز اتش اي في، دي الخطوه الاولى. وفي نفس الوقت دونت فورجيت تو سكرين فور اذر سيكشوال ترانسميتد ديزيز، دي الخطوه الثانيه. الكلام بسيط. نمره واحد زيز اتش اي في، نسبه من اتش اي في. اثنين نشوف الاذر سيكشوال ترانسميتد ديزيز. بعدها بنعمل مونيتورنج. واخيرا بنعمل شنو؟ اللي هي investigation for opportunistic infection and ART side effect. فكره بسيطه. نمشي طوالي للخطوه الاولى اللي هي شنو؟ confirmatory test. بعد next slide لو سمحتي. ايوه صوتي قطع ولا شنو؟ طيب تمام شكرا جزيلا. طيب يلا نمره واحد بدنا نقول اتش اي في. فكره بسيطه شديد. لو ملاحظين هنا مسمين شنو؟ فورس. طيب عندنا نقول الفكره بسيطه. عشان نقول الاتش اي في بنقسم العيانين لتو جروبس. اقل من 18 شهر ده الجروب الاول، والجروب الثاني اللي هو الجروب الاول اكثر من 18 شهر الادلت، وقع عليك، والجروب الثاني اقل من 18 شهر. التقسيم ده على اي اساس؟ لانه الانفستيجيشن عموما بتاع الدبليو اتش او الموجود ده هو عباره عن انتيجين انتي بودي رياكشن، وبالتالي اي زول اقل من 18 سنه 18 شهر او انفنت هيكون في شنو؟ في انتي بوديز فروم هيز ماذر. يبقى هنا الانتيجين انتي بودي رياكشن ما مناسب. هنمشي نعمل هنا شنو؟ الدي ان اي اور الار ان اي بهذه البساطه. يبقى اذا جاني ادلت هعمل له ثلاثه تيستات. اكشولي انا بعمل اثنين. بعمل التيست الاول اللي هو اسمه فورس جنريشن اتش اي في من غير تفاصيل. عندنا التيست 1 بعمله، طلع بوزيتيف. بعمل التيست الثاني، طلع بوزيتيف اتش اي في. يبقى عندي سكريننج الاول بوزيتيف، الثاني طلع بوزيتيف اتش اي في، الثاني لو طلع نيجاتيف انا هنا في الحاله دي حامشي لحاجه اسمها تاي بريكر تيست. حامشي للنظر تيست. تاي بريكر يعني شنو؟ يعني ده نكسر التعادل. دايما التيست الاول بيكون فيري سنسيتيف تيست. يعني داير شنو؟ اي بوزيتيف يطلع عليه. ده التيست الاول. والتيست الثاني بيكون سبيسيفيك تيست. زمان كان في طريقه معقده وطويله ما حتكلم عنها. يعني كان في حاجه اسمها بعد ذاك يمشوا الالايزا ويسترن بلوت. بما انه كلام اوبسكيت نخليه نقول الفكره. يبقى الفحص الاول هو عباره عن انتيجين انتي بودي تيست، فيري سنسيتيف تيست. هيقوم يحاول يجيب لي كل البوزيتيف. التيست الثاني بيختلف عنه شنو؟ في البروسيدر شويه، يعني ما نفس الحاجه اللي استخدمتها شركه ثانيه او اللي هي شنو بروسيدر مختلفه. ده هنا هيكون فيري سبيسيفيك تيست. الاثنين طلعوا بوزيتيف. السنسيتيف طلع بوزيتيف والسبيسيفيك طلع بوزيتيف اتش اي في. انتهى الموضوع. طلع الاول بوزيتيف والثاني طلع نيجاتيف، محتاج لشنو؟ ده هنا تعادل. دي بوزيتيف نيجاتيف، محتاجين لحاجه اسمها تيست اسمه تاي بريكر تيست. اللي هو ده هيعمل شنو؟ هيجي يحسم لي لو طلع بوزيتيف يبقى عندي 2 بوزيتيف طوالي هشخص، لو طلع نيجاتيف هنا عندي 2 نيجاتيف. عشان كده القاعده العامه يعني we diagnose HIV by two tests. يعني single test will never diagnose HIV. طيب نجي للتيست الاول اللي هو ده بتاعنا المكتوب ده. قال لك used for asymptomatic patient اللي هو تمام كده واضح. يلا هنتكلم سريع. انا شكلي اخذت اكتر من زماني شويه ولا لسه؟ طيب قلنا عندنا التيست الاول اللي هي ده بيكون شنو؟ اسمه فورس جنريشن. هو انتيجين انتي بودي تيست. فيه البي 24
جاي.
وفيها الانتي بوديز. الزمن بتاعي فيه كم؟ تفضل تقريبا كم دقيقه معلش.
الزمن انتهى لكن نمر سريع على باقي السلايدز
طيب خلاص نمر سريع ما مشكله. يبقى التيست الاول ده بيكون اللي هو سنسيتيف تيست، عباره عن انتيجين انتي بودي تيست. فيه الانتيجين بي 24 وفيه الانتي بوديز اي جي ام واي جي جي. اذا طلع بوزيتيف نمشي السلايد اللي بعديها. هنمشي شنو عندنا؟ ويندو بيريد برضه اللي هي من 18 ل 45 يوم. ممكن الناس تراجعها. والكلينيكال فاليو. الفكره الاساسيه انه التيست الاول ده فيري سنسيتيف. بعده طيب التيست الثاني هو كونفرماتوري تيست، وده بيكون عباره عن انتي بوديز اللي هو بيفرق لي بين الاتش اي في 1 والاتش اي في 2. هنا ما حيكون في انتيجين. وده هايلي سبيسيفيك تيست. لو طلع بوزيتيف كده عندي السنسيتيف بوزيتيف والسبيسيفيك بوزيتيف. ذيس از اتش اي في. وسكريننج تيست سلايد عاديه تيست عاديه. بعده عندنا التيست الثالث اسمه التاي بريكر تيست اللي هو كسر التعادل. اذا واحد في ديل طلع الاول طلع بوزيتيف والثاني طلع نيجاتيف بنعمل التيست الثالث. اذا بوزيتيف خلاص ذيس بوزيتيف، اذا نيجاتيف ذيس نيجاتيف. انتهينا من دي. ثانك يو. وممكن الناس ترجع للكلام ده. قال لك الكلام ده تحت مهم. important WHO rules اللي هو never diagnose HIV with one test. الويسترن بلوت الان ما شغاله. والفيرال لود بنستخدمه الا في البيدياتريك، بنستخدمه في الادلت. الا لحاجات معينه اللي قدام ممكن نرجع عليها. طيب، عندنا قال لك هاو تو دايجنوز اذا كان اقل من 18 شهر. هنا في الحاله دي بنعمل شنو؟ اللي هي البي سي ار، بنعمل الدي ان اي. الدي ان اي اتس بيتر. وممكن الالترناتيف بتاعه شنو؟ الار ان اي. بس دي الفكره، عشان نمشي قدام شويه نمشي الكلينيكال. طيب، بعده عندنا برضه حاجه اسمها البوست اكسبوجر تيست، معروفه كلها، اللي هي بيز لاين 6 ويك و6 3 مانثs و6 مانثs. بعده نيكست. طيب، نيكست. بعده. صوتي فيه ولا طلعت انا؟
أيوة معاك. وصلنا CD4 count interpretation.
نحن في المونيتورنج.
okay.
بعد البوست اكسبوجر مونيتورنج.
yeah post exposure monitoring test.
ايوه، المونيتورنج تيست. ببساطه المونيتورنج احسن تيست بنعمله الفيرال لود، والسي دي 4 ما بنعمله دائما الا عشان يحدد لي الاوبورتونيستيك انفكشن. يعني ما هو التيست الاساسي اللي بنعمله. وفي السودان للاسف لا عندنا فيرال لود ولا عندنا سي دي 4. بالتالي حنمشي نعمل شنو؟ كلينيكال اسسمنت، وده هتكلم عنه الدكتوره ناديه ان شاء الله. طيب، نجي للفيرال لود. هو قال لك الجولد ستاندرد فور مونيتورنج، وبنعمل اتش اي في ار ان اي كوبيز. والبيربوس اللي هي الاسيس ريسبونس. يبقى الفيرال لود بنعمله ليه؟ تو اسيس ريسبونس اوف اي ار تي. وبرضه بحدد ليه التريتمنت فيلير. وبرضه بنشوف ليه الادهيرنس. بشوف البيشنت ادهيرنت، لانه عمل الفيرال لود لو نزل بتاع. هو لو ما نزل واحد من الاثنين، يا اما نن ادهيرنت او في ريزيستنس زي ما قلنا. بعده هنمشي فيها سريع. وده الديفينيشن بتاعنا فايرال لود. تمام. نحن هسه في الفايرال لود مش كده؟ بعد دخلنا في السي دي 4. يبقى السي دي 4 قال لك is no longer required routinely. بنعملها ليه؟ هي ريفلكت جست الاميون ستاتس، وفي نفس الوقت اللي هي الريسك اوف الاوبورتونيستيك انفكشن، وهي جايد في البروفلاكسس وفي البروجنوستيك فاكت اللي هي ماركر. بعده نيكست سلايد لو سمحت. ايوه. طيب، اللي بعدها قال لك كي كلينيكال انتربريتيشن، اللي هو زي ما عارفين نفس الكلام معاد. اكثر من 500 بريزيرف، 200 ل 500 مودريت، اقل من 200 اللي هي دي شنو ايدز ديفايننج، وده سيفير. نيكست. بعده قال لك اف سي دي 4 نوت افيلابل. ده الكلام مهم. قال لك اف سي في سي دي 4 نوت افيلابل، طوال بعد ذاك تمشي للستيج اللي هي ستيج 3 اند ستيج 4، وهي ايكويفالنت لشنو؟ للسي دي 4 اقل من 200. ودي الموجوده عندنا. طوال لو بعد ذاك ما عندك سي دي 4، ما عندك فايرال لود، تمشي تعمل الستيج. ستيج 1 ستيج 2 طبعا بتعالج طوال، بتبدا ما عندك علاقه بالسي دي 4 الاي ار تي. لكن بالنسبه للبروفلاكسس بتبدا من ستيج 3 وستيج 4. بعده في الكلينيكال مونيتورنج، دي هتكلم عنه الدكتوره. بعده طيب نجي لشنو؟ للسكشوال ترانسميت دي سكريننج، معروفه، اللي هو السيفليس والجونوريا والهيباتيتس بي والهيباتيتس سي والهيومن بابيلوما فيروس والتيوبركلوزس. دي كلها بيحصل لها سكريننج، ومعروف بيتعمل لها كيف. ما نجي فيها كتير. بعده وعندنا الثاني السكريننج اللي هي شنو؟ بتاعت في الانفستيجيشن بتاعتنا للسايد افكت. مثلا زي التينوفوفير بنعمل له اللي هي شنو؟ رينال فانكشن تيست، والبون وزودوفيودين بنعمل لانه بيعمل انيميا، بنعمل تشيك للسي بي سي، وهكذا والاباكافير. وعندنا برضه بنشوف الليبيد بروفايل والجلوكوز، لانها شنو؟ البروتيز بروتيز انهبيتر، ولا اللي هي الريفيرس ترانسكريبتيز، ممكن تعمل ديسليبيديميا وهايبر جلايسيميا. وشكرا جزيلا. لو في زول عنده سؤال جاهزين.
Thank you so much for the well-prepared session. It gives us a deep understanding of HIV, virology, immunology, and clinical correlation of those tests. I'm really happy to listen to you, Dr. Sadig. For the first time I can confidently say إنه أنا فهمت الموضوع ده in depth. Without further delay, I'm going to introduce our next speaker, Dr. Nadia Ahmed. She's highly experienced consultant HIV and sexual health physician. She's based in London, in the UK, primary practicing at the Mortimer Market Centre. She's a part of the Central and Northwest London NHS Foundation. And she's also an honorary clinical lecturer at the University College of London. She has extensive experience in adolescent health and inpatient care, sexual function and gender-based violence, medical lead in the HIV inpatient and outpatient service, and a very extensive experience in service development, implementation, and a young-friendly service for the pre-exposure prophylaxis. Dr. Nadia, we're happy to have you with us today, and over to you.
Assalamu alaikum, everyone. I'm just going to share my slides. Okay, great. So I think I've got a tough act to follow. So I was listening in, but I can't speak Arabic, unfortunately, apart from Yallah, so and some other things. But inshallah, I will learn one day. Um, just to say, it's an honor to be talking to you this evening. About acute HIV infection in clinical staging. Okay, right. Just to check, you can see my slides and moving.
We do.
Yes, okay, brilliant. I think just to say before I start, I was fortunate to visit Sudan a couple of years ago. I went with Shorg, and we did some teaching out there in HIV and sexual health. We were in Umdurman, and I managed to spend a little bit of time and travel around to see the beautiful country that you have. I am very sad about what's happened. It's been a couple of weeks after we left that things um, kicked off with the war. And I really hope things come to an end. So my thoughts are always with you. And I think Sudan really is a place where it restored a lot of my faith in the world and humanity because of how beautiful the people were, but also how I saw Islam being practiced as well. So I hope it's okay that I share that with you, and I was able to see your beautiful country. So inshallah, one day I'll come back. So I'm going to be talking about HIV infection and clinical staging. Um, Sorry, I'm just moving around just to make sure I've got everything sorted, so I can keep a track of time as well. So I'm going to try and keep this interactive if possible, so we can use the chat as well. And I think I can see the chat on my screen, so I'm going to try and keep it interactive. So what I'm going to talk about is a little bit of about the course of infection, so the stages that we see of HIV, and then the classification, and look specifically more at the stages and what they mean. And then we'll go into clinical presentations as well, so where we see CD4 counts less than 200, and also what we consider chronic HIV nowadays. So I think, just wanted to mention, and I know you'll know all of this, about the current what's happening obviously in Sudan at the moment. And in terms of, we know that there's with war, there's a massive impact in so many ways, and healthcare facilities, unfortunately, are one of those that suffer when it shouldn't be. But sadly, it does happen. And it was estimated that 70% of health facilities, that may be more now, are not operating in hard to reach areas. And while, there's some financial support, it's been difficult to get antiretroviral treatment and, re-enrollment in treatment of, thousands of patients who've dropped out of care because of the ongoing war. So, and that, that we can see here the numbers of infection, although this is generally the Middle East and North Africa, are rising. And with, with the other conflicts going on in the region, numbers will rise with HIV. And there's a really great concern about that. But also because of, unfortunately, the weapons of war that are used, so, sexual violence and otherwise that can increase the rates further. So it's really important to be able to identify HIV at the various stages and also consider how to manage that and what to do. So the course of infection, so I know a colleague before mentioned a little bit about this. So just to go into a little bit more detail about this. So when somebody first gets the HIV infection, can you see my mouse moving on the screen, by the way? Can you see it?
Yes, it's
Yes.
obvious, Dr. Nadia.
Brilliant. Okay. So you can see the red line here represents the HIV virus. So when we get any infection, HIV is no exception. When the virus goes in or bacteria goes in, it's going to divide, multiply, replicate. It's taking over the body to do what it does. So it causes the infection. So the HIV virus goes up, 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 up. All right. So it goes really high. What it then does is attacks the immune system, as we already heard. And the immune system, particularly the CD4 cell that it likes to damage, but it also affects other cells, goes down. So you can see it goes down. At some point the virus gets a bit relaxed, tired, just rests a bit and will go down, let's say. And the immune system will slowly try to recover a little bit. But there remains this stage where the immune system the virus is attacking the immune system, but the immune system is fighting back a little bit, and there's a bit of, I guess, it becomes a bit of a plateau and stable period. And then with time, what happens is the virus starts to rise again. It starts to get stronger. It's like it's rested for a bit, but it's just starting to get a bit stronger, maybe a bit more greedier, wants to completely take over the body, and the virus goes up, 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 up. And therefore the immune system continues this time to get damaged till we get immune system levels so low that you see very severe infections, opportunistic infections, and then, without any treatment of the HIV, so this is specific to HIV, deaths will happen. And we have there are different stages. So we've got the first stage, which is the primary infection, or it's also called, seroconversion, acute HIV. And then you've got the clinical latency where it stays stable for a little while. And then you've got AIDS, which is the CD4 count. So the immune system reaches a level of less than 200, or advanced HIV. So there's lots of different ways of classifying HIV. If you look into it, people call it so the first stage, primary HIV, acute or so acute HIV. Then it becomes a clinical latency period, and then you can get another stage called persistent generalized lymphadenopathy. As the name suggests, you get generalized lymphadenopathy. And then your final stage, as I mentioned, is AIDS, acquired immune deficiency syndrome, at less than 200, CD4 counts less than 200. Some people class HIV with acute, so you've got the acute phase, and then it's a chronic condition. And I think that's more so when people are on treatment and established on treatment, and they're doing well, so they don't, they're not at risk of developing symptomatic HIV or AIDS. So they just develop a chronic HIV, which is controlled, and people continue on treatment. Other things, another way of classifying is, acute HIV infection, and then there's a period of asymptomatic. So that clinical latency stage, most people are asymptomatic, or they can have infections that people don't have HIV get, but they're just a bit more troublesome, a bit more irritable, a bit more recurrent and otherwise. And then it develops into a symptomatic HIV and then AIDS. And then you can also have the classification of asymptomatic, minor, moderate, and AIDS. As you can see, I mean, they're all very much the same. It's I don't. The Americans say tomato. We say tomato. So I say this is sort of tomato tomato. Hopefully that makes sense if you're familiar with that phrase. And then you've got the WHO classification, and the other formal classification out there is the American one, so the CDC classification. But why is it important to have classification of HIV and disease? Does anybody want to let me know what they think in the chat? Any thoughts? To guide management? Yes, good. Yes. So it's about guiding management ultimately, but also just a little step before that. Is about recognizing what stage we're at and then think about what differentials we may or may not see. So you can then, so for example, in some countries, people don't have access to CD4 counts or viral loads. They may have access to both. They may have access to only CD4 counts. They may have access to only viral loads. Or it may take a long time for these results to come back. So if you see somebody who has certain infections, I'm not going to name them because I'm going to come on to them, and they are considered, opportunistic infections, which we see when the CD4 count's less than 200, or when somebody's classed as having AIDS, and you don't have access to CD4 counts or viral loads, you can tell this patient is very sick, and this would be AIDS as opposed to, the symptoms that we particularly see with primary HIV or in general. You can try and classify it without testing. So it goes back to your clinical, judgment, back to good basics of medicine where, somebody's got a cough and it's a productive cough and they've got green phlegm, most likely it's a bacterial infection. But in this situation, it then enables you to say, actually, this person has got AIDS, or they're seriously unwell, or maybe they've got asymptomatic HIV if they've got, persistent generalized lymphadenopathy, but it's at a stage before AIDS. But yes, and then it does ultimately, then it guides your management. And then, yes, prognosis as well, because if somebody presents in the category of AIDS, and they're not on treatment, that could be, it puts them at greater risk of death if you're not able to get access to antiretrovirals. But also, if somebody's had more AIDS-defining illnesses but gets onto treatment and they do well, it can just put them at a slightly greater risk. In developing some of the malignancies we see with HIV compared to if somebody's diagnosed very, very early. So it helps us classify it ultimately without the test results, but then helps us know how serious or how sick the patient is, and that guides us our management and prognosis. So thank you for the contributions there. I'm not going to go into this bit in detail. If I read this out, we'll be here all night. So I won't, but you will get access to the slides, so you've got it for reference. So the WHO classifies clinical stage 1, stage 2, stage 3. So if you've got somebody, for example, with unexplained persistent fever, intermittent or constant for longer than a month, then you could see, okay, that's clinical stage 3, which corresponds to certain levels of CD4 counts. If you've got somebody that's, asymptomatic and they have HIV, then again, you can say, right, that's clinical stage 1. Okay, they're not that sick. So we have time, to manage their HIV. But equally, you want to get them onto treatment straight away, as per the lecture before, and guidance around getting people on living with HIV onto treatment early. And then there's a separate classification here you can see for children as well. So, but there's similarities as well. And then you've got stage 4, which is, sort of really your AIDS stage when your CD4 count is less than 200. So you've got your adults and then children. And that's when we see really real opportunistic infections such as pneumocystis jirovecii pneumonia. You can also get, cryptosporidiosis, as well as, things that we could see in people that don't have HIV, but indicates a severity. So, if you have somebody that's come in with recurrent septicemia, and you don't know that they have HIV, you should think, could this be HIV? Make sure they get tested as well. But if you have somebody who knows to have HIV and they've got recurrent septicemia and you don't have access to CD4 counts, maybe this is then, stage, the AIDS stage, so CD4 counts less than 200. So this is somebody who's potentially could develop other infections and could get very sick. So the this is the CDC classification. So the CDC classification then, classifies it according to CD4 cells and then acute, symptomatic, and AIDS indicators. And again, it's it's an old classification. But some places still use it, and it's helpful again in terms of looking at CD4 counts and the symptoms in the same way that I've already explained. You can get AIDS defining illnesses, which is when we see conditions that are when CD4 counts are less than 200, which is AIDS, or you can get indicator conditions. So although it's these are different, sometimes it can get a little bit, it can feel overlapping. And indicator conditions are conditions where if you see it, you should consider testing for HIV in the context of obviously somebody that we don't know has HIV. So, these are things like lung cancer, Hep B, Hep C infection, dementia as well. It should be in the screening of people presenting with dementia, space-occupying lesions, and so on. So it doesn't really have opportunistic infections here. These are often things that could it's rare that not opportunistic infections, but these are things that could be seen in people that don't have HIV. But can equally be an indicator that this is somebody living with HIV, and it should be part of the screening process. We had a lady who had dementia and presented through GP, and she had the full screening tests. We think about syphilis, B12 deficiencies, folate deficiencies, depression. She had an HIV test and it was positive. And once she started on antiretroviral treatment, the dementia sort of went away. So it's really important to still think about it, because then people may get labeled with the wrong cause or an unknown cause, whereas it could be HIV and it could be treatable. So I'm going to ask you again. So I've mentioned, what primary infection is, or acute HIV, or seroconversion. What symptoms do people get when they have primary or acute or seroconversion? So feel free to use the chat. Okay, skin rash, good. Fever, lymphadenopathy, brilliant. Yes, good. So seroconversion, people get flu-like symptoms as well, and they get a rash. They can get lymphadenopathy, as it's been said. They can also get, and this is the flu-like symptoms: chills, headaches, night sweats, sore throat, mouth ulcers, fatigue, joint pain. So all part of the flu-like symptoms. And then an opportunistic infections can also present as well. But your differentials should also include things like syphilis, which can present in the same way, and also things like cytomegalovirus and Epstein-Barr virus can present similarly too. So that was the first stage of HIV. The second stage is in asymptomatic, so essentially no symptoms, but it can give a false sense of security, because we think that people, I don't have any symptoms today. I don't know how many people on the talk at the moment. I saw about 80 to 90. So maybe you don't have any symptoms, but it's important to still test somebody who doesn't have symptoms. So if somebody comes in, it's always good to test, but obviously resources will determine whether you are able to just test in those situations. But be mindful that people, obviously HIV can be asymptomatic. And then you get the persistent generalized lymphadenopathy stage, which, as it suggests, is persistent generalized lymphadenopathy, and it's all because of the HIV. But HIV does increase the risk of malignancy. So in these situations, it can get a little bit tricky, because you need to make sure, this isn't actually lymphoma brewing, for example. So although, people with lymphomas may have night sweats, fevers, weight loss, they may not in the very early stages. So it's always important to ask those features as well. And if there's any concern, the only way to really know is by scanning or biopsying them. So it is a bit of a difficult, but you have to take in that full clinical picture. And if in doubt, just, get them biopsied. Of course, the other differentials could be infection, or of any type. I guess, and syphilis, of course, again, and then not only lymphomas and malignant, but other cancers as well. So always think about that as well. You can get constitutional symptoms, as I mentioned, with these malignancies, the night sweats, fevers, and weight loss, but also it can just be, so although it can be part of the presentation of malignancies, it can just be part of the symptoms that people see with HIV, particularly in the advanced stages. So I always ask patients about it, but it then does become difficult, not difficult, but then you think, oh, have they got, do they have a malignancy? Was this just the HIV? And there's no real way, other than, I guess, other than, you can take a history and maybe they might have a persistent cough, and that might make you think, oh, maybe this is lung cancer. Or, maybe they've got such widespread lymph nodes that you think, could this be lymphoma? They may be a smoker. So you need to sort of add that information with those symptoms to be able to determine whether this could be a malignancy, and then, obviously examine them, and, where possible, if you've got the investigations that you have access to, get those done. But ultimately, again, if there's lymphadenopathy, you'd want to biopsy it, or if there's a mass or something. But sometimes it can just exist, just to be clear, without the context of malignancy in HIV. Okay, so again, the same differentials to consider. We've covered this already. I just want to see if there's anything else so I don't think there's anything else to mention, but it was just another way of showing you the stages. But also, the other reason I've put that in is, if we think about it a little bit further, and again, a nice schematic that you can use, where it just shows you what type of presentations people can have. So in primary infection, you've got the fibromyalgia. People can also get meningoencephalitis with seroconversion. And then in early stages of HIV, where the CD4 count is greater than 500, you can see things like Bell's palsy, Reiter syndrome, Sjögren's syndrome, etc., etc. And then, you've got CD4 counts between 500 to 200. There's infections that we tend to see, or in other conditions that we tend to see. And then when it's advanced at less than 200, you really see these severe opportunistic infections. So candidiasis, pneumocystis, toxo, cryptosporidiosis, cryptococcus, etc., etc. Yeah, and this is just showing you this in another format table. So for your reference, I sometimes put in different ways of showing things, but I think they're nice ways of categorizing it, and nice graphics, and I can't decide which one to choose, so I just put both in, and you've got both of them. This again is something that you could use. It's a summary of, again, the stages, what acute infection is, asymptomatic. I just thought it was a nice depiction of it, with also some images here as well. Okay. Diarrhea, somebody's asked about diarrhea. When you say what about diarrhea you can get during seroconversion, definitely, and we'll come on to the systems shortly, but diarrhea can occur in seroconversion. And thank you for mentioning that, because I hadn't actually put it in. Why do you think, and this is to anybody, but why do you think diarrhea is quite a feature, or can be a feature, of seroconversion, or untreated HIV, outside infections like cryptosporidiosis or salmonella or shigella? Why do you think diarrhea can be a significant feature? Any thoughts? Intestinal vomit. Kind of, you're close. So you can get MAC if the CD4 count is less than 50, but you could also get quite severe, so in also cryptosporidiosis. So remember, this cryptococcal, which can affect the brain, and cryptosporidiosis can cause diarrhea. But basically, even in acute stages, so when your CD4 counts can be good, The immune system is the largest in the bowel. And in the bowel, if you've got the largest part of the immune system, when somebody gets HIV, the immune system is activated. It's where the HIV is going to attack. So therefore, the immune system because it's your largest in the bowel, it's going to be very inflamed, and you can get diarrhea for that reason. But of course, as people are putting into the chat, when the immunity is very low, so less than 200, you can see opportunistic infections like cryptosporidiosis, Mycobacterium avium, Isospora, Isospella as well. But just to say that in the context of CD4 counts greater than 200, the reason why you could see diarrhea without cause is because of it being the largest part of the immune system. HIV attacks the immune system, and so therefore you can get a really significant inflammation. And the other thing is also CMV that you can see in the bowel, so colitis. Okay, thank you again for the interactions. So I'm going to talk about a little bit more detail about clinical presentation. So we've talked so far about the course of the infection, and we've talked about the primary stage, so your seroconversion, acute HIV. We've then talked about the asymptomatic, not much to say about asymptomatic, but it's asymptomatic. And then we've talked about the persistent generalized lymphadenopathy stage. And I've started to show you what some of the infections we see as we advance through the fourth stage, which is AIDS, acquired immune deficiency syndrome, where we have CD4 counts less than 200. So we'll cover that, and then I'm going to talk a little bit about what we call chronic HIV. Okay, so when people present with HIV, remember, consider the staging, the classification, as I've mentioned, to help you determine what stage they may be at according to their presentation. And obviously, if you've got access to a CD4 count, then that makes it slightly easier. There's a lot of sort of rapid testing now available for CD4 counts, or sometimes it can take the lab a day or two, but in some situations it's not available at all. So if you do have access to a CD4 count, that just helps you further. But if you don't fret. The staging can help you as we've gone through. Nowadays, we don't check CD4 counts as regularly, and that is guidance in the UK, but I think it's also global fashion now as well, because really what can happen is the CD4 counts are going to drop in acute illness, and although it's helpful if you see somebody, to keep testing it every day is not going to help you, because we know it's low, it's going to stay low, and it can bounce up and down and fluctuate slightly. So there's natural fluctuation. If the CD4 count is dropping further, so let's say you test it every couple of months for a patient, or every couple of weeks, again, I would say be cautious with every couple of weeks, because it can just naturally fluctuate. But if the CD4 count is consistently dropping, and the percentage is consistently dropping as well, then you should be more concerned that maybe there's a malignancy brewing. Whereas if the CD4 count is dropping and the percentage is rising, then that's a bit more reassuring. And I see somebody said you don't have CD4 counts available in Sudan. Okay, thank you for that. The other thing to consider is that if somebody is not adherent to antiretrovirals, or they're not taking their treatment, so either they take it on and off, or they're not taking it at all. And obviously, with the context of Sudan at the moment, they may not have access to treatment at all. So then we know that their virus is going to be higher. The CD4, there's more virus around to attack the immune system, so your CD4 count's going to be lower. So be very not on high alert, but be very aware that maybe even if they have a cough, that it may not just be a viral or bacterial simple infection, but it could be an AIDS, part of the AIDS defining illnesses, an opportunistic infection like PCP, for example. So be very mindful of that. Okay, so we're going to go into some of the presentations now. So if you have somebody with the neurological concern, they you'll all know this. So they could present with headache, seizures, confusion, visual disturbance, low GCS. They could have focal deficits when you examine them. They may have cerebellar signs. Also, I think we often, I don't guess we don't think of it as necessarily with neurological, but I've thrown in psychiatric or mental health issues as well. And, with that, there may be a slight overlap with confusion where, they may be confused and it's actually a mental health issue. They appear as if they're confused, but actually they've got a mental health issue, or maybe, it's the other way around. What would your differentials be in the context of somebody who has a CD4 count less than 200, and they present with the neurological symptoms? So what are your differentials for opportunistic infections in the brain? Great. So progressive multifocal leukoencephalopathy, or PML, HIV encephalopathy. Yep. So that's a direct effect of HIV. PML is driven by the JC virus. Toxoplasmosis, good. Lymphoma, yep. Fungal infections, cryptococcus, yep. Great. Brilliant. I think you've got all of the key ones. So we've got toxo, yep, abscesses as well. So we've got toxo TB as well. So CNS TB, CNS lymphoma, cryptococcal meningitis. You can get tuberculoma, as somebody said as well. And then also, bacterial or viral meningitis. You can get viral encephalitis, HIV encephalopathy, and syphilis. I'm an HIV physician, but also trained in sexual health, and syphilis is, think about it all the time. So, of course, if somebody is not acutely, with advanced HIV, they could have had a stroke, or, it could be because of medications or recreational drugs. And I see other people have mentioned, let me just see here, neurocysticosis, and also dementia as well. So good, yes. So if you've got untreated HIV and tuberculosis, you could see dementia as well. So good. In terms of the investigations that you want to do, so depending on what you have access to, so please do let me know. Usually what we do is cryptococcal antigen, and that can then rule out cryptococcal meningitis. So if that's positive, that's a good way of thinking, okay, is this cryptococcal meningitis? Right, it's negative. No, it's not that. Toxoplasma serology can be helpful, but can also not be helpful, because somebody may be positive for toxoplasma, but it doesn't necessarily mean their presentation and the findings are as a result of that. It might just be that that somebody's carrying it, but if they carry it, there is the risk of reactivation. So it helps if it is positive, because you could include it with your differentials. If it's completely negative, that can be helpful, because then you think it's highly unlikely it would be toxo, but also because the immune system is so damaged, it might be that the body hasn't made a response to the toxo that's there. So it's variable compared to cryptococcal antigen. If it's positive, it's got a very good sensitivity. And then you can also check for your CMV titers, so viral loads and EBV viral loads, which again, there's some differences of opinions of how to interpret, particularly CMV, but that's that. Obviously, to say you would do your usual tests, your blood count, your kidneys, your liver, your bone. Somebody who presents confused could also have liver failure, kidney failure, because they're confused. It could be step sepsis, but just thinking about the opportunistic infections here. Ultimately, with neurological presentations, you'd want to do a CT head, and if possible, an MRI head, because MRI just looks at the brain better, but conscious of what may or may not be available. And then really what you want to do is go on to a lumbar puncture, where you would do the usual, so your proteins, your biochemistry, etc. You would do cryptococcal as well. Again, very sensitive. Toxo PCR is a bit better compared to the serology in the blood. And then also syphilis, remember syphilis in the blood as well. And then MCNS, AFB, TB, a viral panel. So your encephalitis could be caused by HSV, VZV, CMV, EBV rarely, but possible as well. And then HIV itself, you can check your levels. If somebody's got untreated HIV, though, the virus in the CSF is more than likely going to be present. So although it's not really helpful, I would say, in the acute stage. So it's more if somebody is on treatment and controlled, and they present with cognitive issues, and you worry about the virus escaping from the blood into the CSF, which is a whole talk on its own. So those are sort of the investigations you would do. I think just to put it into a bit more context, I always feel if somebody has headaches, that's a really strong feature of cryptococcal meningitis. So if they've got severe headaches, and then the other thing that helps with the clinical picture, because I'm conscious of the situation, the access you may or may not have. So I'm trying to add in sort of clues to how to diagnose if you do come across this. Headaches, I always think cryptococcal. Toxo can be very variable, so it's a bit more difficult, a bit more trickier to say. But things like the encephalitis, you'll have people who've got confusion, maybe personality changes, and then meningitis, you will have somebody who's got nausea, vomiting. They may have neck stiffness. You've got the typical signs and symptoms of meningitis. Dementia, obviously, or cognitive issues, are cognitive issues, and then TB. Somebody might have night sweats, weight loss, and also with malignancies, they may have that as well. So hopefully those are ways that you could piece it together without access to some of, or if not all of, the investigations. Okay. Just to say that all patients with a positive serum cryptococcal antigen need an LP, so you should always do an LP for them if that's available. So somebody's put a question in the chat. What about ART for low GCS state patients? You wouldn't. I'll come on to that. So we wouldn't give antiretrovirals in the context of opportunistic infections immediately, but I'll come on to that in a couple of slides. Can anybody tell me what this scan shows? So this one, or this one. Multiple ring enhancing lesions, good. So, and that's typical of. So what causes multiple ring enhancing lesions? Toxo, good. Yeah, so toxoplasmosis, brilliant. Good. You could also say maybe that could be an abscess, it could be a cryptococcoma, it could be a tuberculoma, but most top of the list should be toxoplasmosis. The only way we're going to definitively know is biopsying, but even that's something you wouldn't do unless somebody wasn't getting better or they were getting worse. And in this scan, what does that show here? What might this be? Yep, leukoencephalopathy. Good. So you can see there's sort of white area here in the grey matter. So you've got toxoplasmosis, and then you've got progressive multifocal leukoencephalopathy. Good, well done. So I just wanted to show those. The other thing is, I'm not going to go through this in detail. I'm sure you know CSF interpretation well. But the main thing I just want to say is, I always think I used to hate CSF interpretation when I was a medical student and a junior doctor. But anyway, you finally clock it at some point. You've got polymorph nucleus, that's what we see in bacteria. You've got lymphocytes, is what we tend to see more in. I see somebody else doesn't like it as well. Lymphocytes is what you tend to see in viral infections, but also in TB, bacterial cryptococcal meningitis and lymphomatous as well. But the difference here is the glucose. And normal is obviously normal, but cryptococcal meningitis, you'll see, could be completely normal. Lymphocytes and present with lymphocytes as well. If you've got a CSF that's completely normal, what's the other? Yes, exactly. That's how I used to remember it. So Zilan has put in bacteria loves sugar, so it's low. That's how I used to remember that added change as well. Thank you for sharing that as well. If it's normal, cryptococcal meningitis, does anybody know what other test you can do when you're doing a lumbar puncture, and the result being very typical for cryptococcal meningitis? Not cryptococcal antigen, but something else. I'm sure you India Ink. Yeah, so India Ink is what you do to get the cryptococcal antigen test. So that's good. But there's another thing that you would do, something else. So it's not a test on the CSF that you send it to the lab. It's something you can do. So ZN would be opening pressure. There we go. So ZN would be for TB, but it's what you would want to do is opening pressure. So the opening pressure is very high in cryptococcal meningitis because the coccal infection, what it does is blocks the ventricle, so your pressure gets very high in the brain. So people can have quite serious hydrocephalus, and they may need serial lumbar punctures to get rid of the fluid. And even, they may need to go on to having shunts to be able to manage the level of fluid. So opening pressure as well. So if you had a completely normal CSF, but for whatever reason you are highly suspicious this is cryptococcal, by doing the opening pressure can help you with that final clue to say, actually, could this be cryptococcal while you're waiting, for example, for the India ink to come back. So in terms of management, cryptococcal, so as I said, if the CRAG is positive, then think cryptococcal meningitis. Treatment would be flucytosine and liposomal amphotericin B, but I'll come on to something about that in the slide. And plus or minus serial lumbar punctures, like I mentioned, may even need a shunt. If there's brain lesions, what we would tend to do or advise is to treat for toxoplasmosis. And then if somebody's not getting better, so you can see in this algorithm here, if they're not getting better, then you would need to consider a biopsy. But if they're getting better clinically and radiologically, then, we can pretty much say this is toxoplasmosis. There are other things in that algorithm. If somebody's from a high endemic area of TB, they've got night sweats, fevers, and you do a chest X-ray consistent with TB, then consider TB. CRAG is how you would, if that's positive, then you consider cryptococcomas. So this is quite a nice way of thinking about HIV in the brain. Steroids are given. I see some people have mentioned, I think, pressure and meningeal enhancement, obstructive hydrocephalus. So if the pressure, for example, is very high, or there's evidence of cerebral edema or obstruction or a meningeal enhancement, then you would want to give steroids. But steroids can mask the presentation. So in toxo, if you've given the treatment and then you've given steroids, it might be the steroids that are improving it. And when you stop the steroids, the lesions could get bigger again, in which case you must think, is this something else going on and not toxo? Or maybe you just need second line treatment. You may want to consider, if you've got somebody who's got neurological presentation and you're waiting for some of these tests to come back, to add in antibiotics and antivirals to cover broadly. And then, once you get some tests back, then you can consider changing it to the appropriate treatment, or maybe you continue it alongside as well. And they may need anti-epileptics only if they have seizures. We would not recommend it to be given it prophylactically. So only if they develop a seizure. There was a recent study, I say recent, it's now a couple of years ago, which looked at cryptococcal meningitis treatment, because often the treatments are expensive and it's difficult to get. So the WHO has now worked this into guidelines that if somebody has cryptococcal meningitis, they can be treated with a single dose of liposomal alpha-tericin B with 14 days of flucytosine, and then give them fluconazole, because fluconazole is much more widely available in sort of global south countries. So this has changed guidance as well. So just to mention that. Now we're going to move on to the GI issues. So if we think about the gastrointestinal tract, you always look for candidiasis. Again, remember, we're thinking about the CD4 counts less than 200. So I'll come to that question in a second about brain imaging. Actually, let me answer that now. So if the questions Ilana's asked is brain imaging mandatory prior to an LP in limited resources? What I would say is that what I would do is check clinically I mean, you can say it's mandatory, but I think if, it really depends on what you have available, your resources, your settings. Is the patient really sick? If you're able to get an LP done, it will help you guide your treatment. So what I would say is you go back to your clinical examination. So see if they've got signs of raised intracranial pressure. And then, you could do it based on that. So exactly, somebody said they'd look at the back of the eyes. If they've got papilledema, then, I would say don't do the LP. But if they don't, and then you could consider doing an LP and take a small sample. So while, we want to say it is mandatory, you should, in resource limited settings, you can go back to clinical, the clinical signs. I think sometimes, in certain settings, you've got the luxury of testing that, people don't even examine, but we'll go back to the basics and I say the beauty of medicine really there as well. So really good question. So thank you for asking. Um, Upper GI issues. So in the mouth, starting with the mouth, you can see candidiasis, oral hairy leukoplakia, mouth ulcers as well. And they could just be aphthous ulcers or HSV. And presentation typically tends to be, there could be no symptoms at all. But if somebody's got it, somebody's got candidiasis down the, into the esophagus, and they could have odonophagia, so pain when swallowing, or maybe even dysphagia, and then weight loss because they're not able to eat. It's painful to swallow, so they may start, losing weight as well. The bottom picture here shows oral hairy leukoplakia. This is candidiasis. Do you know how to tell the difference clinically if you were examining them? Yeah, exactly. So the oral hairy leukoplakia, so the one at the bottom, tends to be on the side of the tongue, and you can't scrape it off. Whereas candidiasis, you can see here, can be all over the tongue and the roof of the mouth as well, and you can scrape it off. OHL is driven by EBV, and Candida is obviously caused by Candida. Um, so that's upper GI presentations. In terms of lower GI presentations, people can have vomiting, abdo pain, diarrhea, rectal symptoms of bleeding. They can have weight loss as well. Again, for similar reasons because they're not able to eat. And also, I've thrown in here renal and liver impairment into the GI tract, or the abdominal area. So your differentials here, and some of these things we've already mentioned, or you've mentioned some of these. So you can have infectious gastroenteritis, CMV colitis. Typically, we would see CMV at less than CD4 counts less than 50, cryptococcal and microsporidium at less than 100. If it's above that, it's highly unlikely. So if you've got somebody who's got a CD4 count of 150, you're less likely to be thinking this is CMV or crypto, and you could think maybe this is infectious gastroenteritis. But on the flip side, if you've got somebody who's got really severe diarrhea, and you don't have access to CD4 counts, and they've got candidiasis, you could think, maybe the CD4 count's less than 100 or 50 or less than 50, and maybe this is CMV or crypto. So look at the whole patient, look at the other things that they're presenting with. If they've got really severe weight loss as well, then guaranteed, that it could be less than 100. So you think about the other infections. Of course, and you can see bowel cancer, inflammatory bowel disease, STIs, parasites, and recreational drugs and medications also causing lower GI, but that would be it doesn't matter about the CD4 count. And yes, Giardia is very common as well. And again, you can see that at any stage of the CD4 count. Thank you for that. In terms of your investigations, your stool sample, so send off as much poo as you can, bacteria, viral, OCP, if you're able to. Otherwise, it's you're going to be treating empirically according to what you think might be going on. Something like crypto tends to be very, really high volume diarrhea. So again, that's your other clue. I know that can fit in with cholera and thinking about, sort of war settings as well. But if you've got really high volume diarrhea, think about crypto. If you've got bloody diarrhea, maybe that's more of a gastroenteritis. And colitis as well. So think of it that way. Fecal elastase, we do see that in chronic HIV where people have a low level of the enzymes, and that's because of HIV itself, but also some of the antiretrovirals. And that can result in proper problems with absorption, so they get diarrhea. It's usually treated with Creon, which is a supplement that it supplements the elastase. But again, that's more in chronic HIV rather than CD4 counts less than 200. Of course, always remember hepatitis. If somebody's got abnormal LFTs, think about Hep B, Hep C, CMV, EBV, but also CMV in the context of colitis as well. Diadenosine can also affect the liver. It's a very, very old drug. I don't think anywhere uses it anymore, but it may creep up here and there. And also, when you're managing these, assessing these patients with lower GI symptoms, the other clues, in the absence of some of these tests are, ask a sexual history, have they been sexually active? And unfortunately, obviously in the setting of war, there could have been rape. So asking sensitively about that to think, could this actually be an STI that's causing the diarrhea? Travel, if they've been moved from one place to the other, their access to water, maybe that's not being completely sanitized. So that will help you put clues together. Family history would be more for, cancers maybe, or inflammatory bowel disease. Where you've got access, imaging would be helpful. So whether that's ultrasound or CT, and then, if you've got access to and people are not getting better with smaller with initial management and then ongoing management, then maybe you want to consider endoscopy, and that would be upper or lower, really, plus or minus biopsy. But again, appreciate that may not be available. So the other thing, while I'm talking about sort of the lower GI tract, although it's in the abdomen, is just to stress that, with people living with HIV, if they've got kidney or liver abnormalities, think about the workup as you would with somebody who doesn't have HIV, but also you can get some specific conditions. I mean, with the kidneys, it's mainly antiretrovirals or HIV itself. And with the liver, think about Hep B, Hep C, CMV. Rare that it's HIV itself, but, the drugs, as somebody mentioned, diadenosine, but also things like efavirenz and nevirapine. But again, those are sort of whole talks within itself, but I just wanted to throw that in just as a reminder. I think finally, chest presentations. So, shortness of breath, cough, plus or minus a sputum, chest pain, hypoxia. People desaturate on exercise as well, fevers, night sweats, and you can get weight loss. If somebody desaturated on exercise, what would that make you think of? What infection would you think of? PCP, brilliant, good. So PCP. So again, in the context where you don't have the tests, if somebody comes in with cough and it's a dry cough. So PCP typically has a dry cough, and they don't, so they won't have sputum. But you think maybe this could be viral. If you get them to do a little bit of exercise, walk up and down, and they desaturate. So exercise oximeter, somebody said, that would give you a clue that could this be PCP. If they don't desaturate, then maybe it's just viral and that's it. So that, it's an important way to determine it. If they've got sputum that's green, then for me, that's bacterial, etc., etc. Yeah. So differentials for chest symptoms would be, bog standard. Sorry, that's a UK phrase, it's bog standard. So just normal bacterial pneumonias, but they will tend to have green phlegm there, or they might have yellowy phlegm. PCP or pneumocystis jirovecii pneumonia, which is more the proper term. We've got typical symptoms like, shortness of breath, a dry cough, desaturation on exercise, and also when you listen to their chest, it tends to be normal. So again, you should be able to get the diagnosis without any tests at all. Viral, again, tends to be more of a dry cough. I've, talked about the difference between the dry cough and PCP, so that will help you diagnose. TB, you tend to see with night sweats, fevers, weight loss. A CMV pneumonitis is possible, but that tends to be very, very sick patients. So these are your patients on ITU who are really sick. So, and then fungal pneumonia, similarly, very sick patients who are very profoundly immunosuppressed. So if somebody's taking steroids or getting chemo as well and really immunosuppressed, that's when we tend to see those. Of course, you can see things like lung cancer, and people living with HIV are at greater risk of cardiovascular disease as well. These are just some images of some chest x-rays. So I think in the interest of time, I'll just go to mention, so this is PCP. You can see here, this could be TB or lung cancer or pneumonia. And then this is very typical of miliary TB at the bottom. Okay. The management for chest symptoms. So if, you can go in your clinical the clinical picture, but you can also do beta D glucan. So beta D glucan is a test that's become available and is positive in fungal infections. So it's not exclusive to PCP, but it is helpful. And then radiologically, chest X-rays are helpful. But if the chest X-rays can be normal, you could go on to CT. And then somebody mentioned BAL. So BAL is really helpful, and ultimately that's what you need to diagnose PCP definitively. But obviously, in the context of whether it's accessible, you can see how you can easily diagnose it without any investigations and just clinical acumen. So you would send, the bronchiolar lavage for PCP, PCR, also, microscopy, cytology, and the usual. It's treated with cotrimoxazole, plus or minus steroids. If they're very hypoxic, you'd give steroids, and then general supportive treatment. People who get PCP often need high flow oxygen, or they need CPAP before they get better. But or sometimes they don't. So galactomannan can be used for more of the other fungal infections. It's more helpful for those. If they, consider second line treatment or differentials if there's no improvement. These are just lots of images of other things that you can see. This is, I just want to point out some of these things. Oops, sorry, I've just closed that. So you've got, zoster, this is Kaposi sarcoma, seborrheic dermatitis. That's some papilledema there. So we were talking about that earlier. Somebody who's got wasting, candida, OHL, which I've shown you already. This is, you can see here, exudates. That's most likely CMV retinitis. You've got lymphadenopathy here. This is a cervix, which you can see most likely cervical cancer. And then this is a rash here. You can see it's quite typical of syphilis, or it could also be no, sorry, yeah, syphilis. And then this, I have to confess, I'm not sure. So sorry about that, but I'm sure that's not too much of an issue. Okay. And somebody's mentioned HPV, yes, so that drives CNN. So just I think finally for this section, and then I've just got a few slides on chronic HIV. The other things to remember, CMV retinitis, toxoplasma can also affect the eyes. So if anybody's got any eye symptoms, what I would say is have a look at the back of the eyes, and see what you can see and treat as appropriate. Kaposi sarcoma, you can see on the skin. I've shown you a picture of that. You think about, the skin. There's lots of presentations there. In the genital area, you can get recurrent or severe candidiasis, herpes. You can get, zoster all over the body. It's very, I say common, but, particularly low CD4 counts, lymphadenopathy we've discussed, and then sepsis as well. So people can get very sick with bacterial infections and otherwise. Always ask about fevers, night sweats, and weight loss in people living with HIV, particularly because of the higher risk of lymphoma and TB, depending on where they're from. Just to say, with HIV in general. HIV can obviously result in the opportunistic infections if you've got if you're very severely immunosuppressed. But generally, HIV, even if somebody's well controlled and on treatment, conditions can be that we see in people that don't have HIV, and it's a common things, but also rare things can present, but they tend to be very atypical or unusual in their presentation. They can be recurrent or troublesome in whatever way, and also severe. So, if you see, for example, herpes you can see very commonly in people that don't have HIV, but in HIV it might be fine and, the usual presentation, but it could be very atypical, unusual, recurrent, or severe. And there's a stress even with a good immune system. Okay. General opportunistic management, if you're unsure, but suspect it, thinking about the clues we've discussed in the absence of investigations, just treat it. If they're not getting better, then, reconsider your differential, consider second line treatment, or think about drug resistance. Drug resistance is quite rare, but what I would say is in your context is think about the clues, treat it, and then think, is there something else going on? And then see how you go. You could consider also, just blindly, as they're covering for viral, bacterial, or fungal infections. I mean, the fungal treatment tends to be a bit more toxic, so be cautious with that. But yeah, bacterial and fungal is what I would say. You can do your broad covers there. Somebody asked about antiretroviral therapy. So, in the context of HIV, in the context of opportunistic infections, we always are cautious, and there's always a lot of pressure to actually start antiretrovirals. But if you start too early, there's a good risk of something called IRIS, so in immune reconstitution inflammatory syndrome. And so what happens is when the immune system is very low, but even if it's slightly normal and you've got untreated HIV, when you start throwing in antiretrovirals, the immune system is starting to recover, and the recovery can result in almost like an overactivation of the immune system because it's recovering and then it's recognizing there's an HIV in the body, so it's going to start attacking it to help the antiretrovirals get rid of it. If you've got an opportunistic infection, you've got the opportunistic infection it's trying to fight and manage, but then you've also got the HIV, and then you throw in antiretrovirals. It's like the immune system's almost in a party that it doesn't want to be in. So the immune system can really overreact and be very inflammatory, and you can get like an overreactive immune system. So we wait a little bit for the immune system to kind of get used to the infection that it's treating and the antibiotics or antivirals, and then we wait 2 weeks generally to then start antiretrovirals in the context of opportunistic infections. It varies with other infections. So, for example, cryptococcal, we wait about 4 weeks, and then TB, meningitis, it depends on, and TB generally, it depends on the CD4 count level, and that can vary. So, antiretrovirals we don't start immediately because of the risk of IRIS. And if IRIS does occur, what we tend to do is sometimes it doesn't need treatment, but most of the time we would give steroids. If you get an iris of the brain, it can be very serious because obviously the brain, if that inflames, it's where it controls all of the body really. So you can get people that are very sick. So steroids are given to treat iris. There is another type of iris where people can be asymptomatic. They get antiretroviral therapy, and because the immune system is recovering and fighting back, it's very vigilant. So it manages to find, for example, latent infections, and then the infection presents itself. So TB is very classically described. If people got latent TB and the immune system is activated, you can get TB iris. So in those situations where the infection is unmasked, we would treat the infection and give steroids as well, and continue the antiretrovirals. So we'd still continue the antiretrovirals as well. So that's why we'd be very mindful of it. This is just an image that was nice. So in the final couple of slides, I'm going to just go through clinical presentations that's about more chronic HIV. So if people nowadays are living longer with HIV, as mentioned at the beginning, in this situation in Sudan, access can be limited, and in war settings elsewhere, people don't necessarily have the access to treatment, for obvious reasons. But you can get people that do have access to treatment and they're living well with HIV. And, inshallah, when the war's over, we'll hopefully see more of this. I say hopefully see more of this, but we don't want to see this for people living with HIV long term, but it will be more this that you're seeing rather than opportunistic infections, which can be, really serious. So more likely to present with non-HIV related new medical conditions or no known comorbidities in people living with HIV who are on treatment and well controlled. There's also people living longer with HIV now because of good treatment that's available. So they will have other needs which are not HIV related. But also we can see the long-term effects of HIV and antiretrovirals on the kidneys, cardiovascular, bones, and also weight as well. So these are just other things to consider outside the context of opportunistic infections and when we're thinking about controlled HIV. So, the brain, we've talked a little bit about that cognitive, you can get cognitive impairment, reduced bone mineral density. So we can see increased osteoporosis or osteopenia, cancers, even if somebody's well controlled, greater risks of various cancers, cardiovascular disease itself. So HIV can be a risk factor for cardiovascular disease, and then renal dysfunction, and then also co-infections, this HBV, CMV, and also HCV as well. So HIV in the kidneys. So you can get some of the antiretrovirals. I know dolutegravir is now, sort of globally used as TLD or within TLD. And what that does is it causes a biochemical rise in creatinine without affecting the GFR. So it's an artificial effect. It doesn't damage the kidneys, and it's like what we see in trimethoprim. So just be mindful of that. Tenofovir, my previous colleague that presented mentioned this can affect the kidneys, so you can get tubular dysfunction and then can cause Fanconi's. Atazanavir, less used now, can cause stones. You can get a direct effect of HIV on the kidneys as something called HIVAN, HIV-associated nephropathy. In the UK context, but also, we see a lot of people using chems or so recreational drugs. So ketamine, for example, can affect the kidney, but also globally, people that go to the gym can use creatine supplements, and that can artificially affect the kidneys as well. Okay. Cardiovascular disease, there's an increased risk, and you can see here the mechanisms that as to why it happens. And statins have been really shown to be benefit to, I think, anybody in the world, doesn't matter whether they have HIV or not, but also particularly in HIV. I'm not going to go through the detail of this, but you've got the slides, so you can have a look, and it sort of talks a little bit about the mechanisms of how it can happen. But generally speaking, HIV, there's a virus in the body. It causes inflammation. Having something in the body that shouldn't be there will activate the immune system, and that can cause inflammation. So you can get vessel inflammation, and that leads to cardiovascular disease. But also some of the antiretrovirals have been implicated, but there's also some understanding that's not known as well. So there was also a study recently that was done that showed people living with HIV benefit from statins, even if they have a normal cholesterol, if they are less than the age of, greater than the age of 40, even with a normal cholesterol, statins can reduce the risk of heart disease by 30% in people living with HIV for the reasons that I mentioned. So really good benefit of being on a statin. And it was a global study here. You can see where the countries that it was done in. The other thing to mention is about weight gain. There's been a lot of debate about this in the world of HIV, about whether antiretrovirals do or don't. And currently the evidence says that, drugs such as efavirenz and tenofovir are weight suppressive. So if somebody comes off those drugs, their weight could gain weight because they were suppressing it before. And other drugs like integrases, so that would be something like dolutegravir, which is in TLD, and tenofovir alafenamide, a different version of disoproxil, are weight neutral, so it doesn't implicate it. But there's been a lot of discussion about that. And also when people start treatment, their weight gets better, weight increases, so it's sort of a healthy return to weight. And of course, there's lots of other drugs that can be associated. So think about what else they're on. But often, I think, they think the major driver of weight is appetite, and that can be linked to antiretrovirals, but also always remember diet. A lot of people, they need to just have what they're able to have, particularly thinking about, war settings, but, also they may not be able to access food, but even in the non-war settings, diet and exercise are really important to consider, because often that's not happening. I think that's it. So the final thing I just wanted to say is just remember, if somebody's living with HIV is controlled, they're undetectable, they are so that means their virus is controlled, they cannot pass on HIV. I always just want to stress that because, transmission can be stopped. And, just going back to the beginning where we said, where I mentioned that, obviously access to treatment is of concern in Sudan. So rates of HIV can rise and uncontrolled HIV, but always remember getting people onto antiretrovirals can reduce transmission ultimately, but I know it's easier said than done. So in summary, we've covered staging, classification, and that helps with knowing the severity and also being able to diagnose. So I would say, do we really need a CD4 count if you can assess somebody and you can pick the symptoms and the signs, and think about your system. So think about the neurological, the chest, the skin, the GI tract. Treat for an opportunistic infection if in doubt, and you highly suspect it and you're not able to get the tests back. And we've talked about some clues to that. And antiretrovirals are given, as I said, slightly delayed and when appropriate. I just want to thank some colleagues where I've used some of their slides, and also some resources, and happy to take any questions if there's time. Apologies, I have run over as well, but I hope that was useful. Yeah. And thank you very much for the engagement. It's been brilliant.
Thank you, Dr. Nadia Ahmed. Very articulated, and it gives huge insight on HIV, acute infection stages and systems involved. Thank you for your time and thanks for being with us today. So Dr. Sadig apologizes as he goes for a family emergency. So regarding any questions for Dr. Sadig, just write it in the chat box and we'll answer that with voice messages on our Telegram that you can go back anytime you want. Now, question. I'll start with my question, Dr. Nadia, if you don't mind.
Yes, of course. Yeah.
So my question is, like early ART, is it meaningful in preserving immune function beyond the early infection and chronic infection? And questions is open for the audience as well. You can raise your hand and you'll be unmuted.
Right. So, if early antiretroviral therapy, is it better for preserving the immune system? Yes. So, yeah, in short, yes. But also, I guess it's more about earlier diagnosis. So the earlier you can diagnose somebody when they've acquired HIV, the less immune system damage there will be. So, if you imagine you've diagnosed somebody on day 14 after acquiring HIV, or let's say day 30, compared to 10 years down the line, there's 10 years is going to have caused way more damage to the immune system compared to 14 days or 30 days, and so on. So I think that sort of speaks for itself. So if you start earlier, you can preserve the immune system function in that sense. So you said about early art, but also then, yes, early art would apply in the same way. So definitely. So it's a really good question because, previously treatment was given according to the CD4 count. And over time, I think our understanding has, really been very clear that starting earlier can benefit people living with HIV, not just for HIV related infections or comorbidities, but because of non-HIV comorbidities such as cardiovascular disease and so on. So I think it's a really good question. So it is sort of more of a global drive now, well, not now, but for the last couple of years around test and treat. But the other thing I would say is that people need to be ready to start treatment. Some people are totally ready. But some people do need longer to get used to it and familiar with the HIV diagnosis because it can still have a huge stigma as well. So in summary, I would say yes, definitely earlier antiretrovirals, but with that earlier diagnosis can help preserve the immune function, and that's because of your cumulative damage to the immune system. But also just to add on to that, the lower the immune system or the more damage there is, the more it needs to recover. But also there may be a slightly greater risk, even if you're controlled and on treatment, to malignancies later down the line as well.
Thank you. Rayan Tunja, go ahead.
Assalamu alaikum. Good evening. I would like to welcome all the audience we have today. And thanks, Dr. Nadia, for this elegant, informative presentation that add much more to our knowledge. I would also thank Dr. Sadik. He's a non-teacher for me, for all of his colleagues, that all people he met him used to teach and give knowledge. I would like also to welcome Dr. Nadir Abu Zaid. He's a microbiologist and associate professor on Durman Islamic University. He has a question in the chat box, but he can feel free to unmute himself.
Oh, okay. I think I might be able to. So HIV treatment interactions with HBV. What is solution if there's co-infection? So basically, actually, HIV treatment is the same for HBV. So hepatitis B, we would treat with tenofovir disoproxil or tenofovir alafenamide plus lamivudine. It's very rare and it's not sort of recommended to give lamivudine alone because of resistance being picked up or resistance that is possible for HBV infection. Oh, have I muted myself? Oh no, that's something
Can
you're
hear
asking
you.
Dr. Oh, sorry, you're asking Dr. Nadia too. So yeah, so it's the same treatment that's used to treat Hep B. The only other treatment is entecavir, which may be needed in some situations, but you can often work yourself around the drug interactions. There's a good website that can be used. So I think it's less of an issue, is what I would say. But I may have misunderstood your question. So if that it does answer it, let me know. Or if not, if you're able to unmute and clarify. But I'll put in the link about the HIV drug interaction checker. So it also depends on what the drugs are and the interactions are and so on. Okay, cool. But anyway, now that we mentioned interactions, that's the drug interaction checker we use. It is available on an app as well, and they don't just have HIV drug interactions, but they also have like COVID treatments, which I guess is more of a thing of the past. But they've got a hepatitis website. They do risk calculators as well. So there's lots of things. So use good resource. Um,
Any more questions? Feel free to raise your hand or type in the chat box.
Okay, so question about pregnancy. So it does vary, but you can give, I mean, the most evident, it tends to be more evidence with antiretrovirals and pregnancy. So a question was about first line treatment for antiretrovirals in pregnancy tends to be some of the, I say older drugs, but it's things that are very much used. So things like efavirenz, nevirapine, is fine in pregnancy with the usual backbones of tenofovir and emtricitabine. Also, the protease inhibitors, so darunavir, ritonavir. The newer drugs, so you've got TLD, which is tenofovir, lamivudine, and dolutegravir, which I know is sort of WHO recommended, and I think that's also what's used first line in Sudan, as along with the other options as well. That is fine to give in pregnancy. So I would say first line, you can give any of those options. But it would depend on then, the history of the mother. Are there reasons that you can't give one over the other? Um, and are there any other medications or drug interactions and so on? But also, I would say, given the setting that might be happening, obviously with the wood and access to antiretroviral, what you're able to, the newer drugs have less evidence. So we tend to give the ones that we're able to, and there's more evidence with. But that would vary, and I think according to also your local guidelines as well. So hopefully that's answered it because it varies country to country, but globally, TLD is now given, but there's no antiretroviral that I'm just thinking about now that is contraindicated in pregnancy. Even the newest ones, while there's little data, there's things that are favored. So even tenofovir alafenamide is less favored because of less evidence. So it would go on the, sort of the evidence of antiretrovirals. So that's answered that. How effective is post-exposure prophylaxis in preventing HIV? It's about 80%. So post-exposure prophylaxis, and the earlier that it's given, the better. So less than 72 hours. It can only be given within 72 hours, sorry, and the earlier the better, but it's about 80% effective at reducing HIV. So thank you, Rana. So I have a question about the time of starting antiretroviral in a patient presented the first time with an OI with a low CD4 count. So it would be approximately 2 weeks. Generally, it can depend on the OI. So if it's cryptococcal meningitis, we'd wait 4 weeks. TB varies, so it depends on the CD4 count, but generally it's about 2 weeks for opportunistic infections. But even then, it depends on the clinical picture, the radiological picture. But I would say generally it's 2 weeks, except in cryptococcal where it's 4 weeks, and then TB, it depends on the CD4 count. Cool.
Another question, if that's okay.
Yeah, of course. Yeah, Ryan.
So, in the current war in Sudan, RSF
Yes.
using sexual violence as a weapon.
Mm.
Are PrEP users creating a new diagnostic blind spot for HIV in the acute settings?
Are PrEP users, did you say, or PEP?
PrEP.
Sorry, PrEP. So, and can I just check? Do you mean in the sense that if they're on PrEP, you won't diagnose you're not going to see HIV, or I just want to clarify what you.
Yeah, exactly.
So PrEP is about 80, so it can be up to, some of the studies have shown, so PrEP, but for everyone is, so PEP is obviously after the exposure, PrEP is before exposure. So if somebody's taking PrEP, HIV PrEP, the drug usually given is tenofovir and emtricitabine. For PEP, it's tenofovir, emtricitabine, and something like raltegravir, dolutegravir, protease inhibitors were given as well. So it depends on what you have access to, but PEP after exposure would be triple therapy, but PrEP pre-exposure would be tenofovir and disoproxil and emtricitabine alone. So your question is about whether it would mask the diagnosis of HIV. That's right, right? So basically, it's about 86% effective. So as long as somebody's taking it properly, it should actually prevent HIV. And the data is actually better, I would say, compared to PEP. There are some studies which have shown even 99% efficacy. And those studies that showed really poor results, and there are some tests that have shown, studies that have shown 40 to 50 to 60% effect. It was because of adherence. So I would say it's not masking diagnoses, but it's actually stopping people getting diagnosed, as in stopping HIV. So it's a good thing. So yeah, does that answer?
Yes, certainly. Raya, over to you.
So it's a good, effective method of preventing HIV altogether. Yeah.
Perfect.
Yeah. Oh, sorry, there's a question in the chat. So role of Septrin as chemoprophylaxis. Oh, yes, so there's a really good question. I didn't mention prophylaxis, but Septrin or cotrimoxazole, if the CD4 counts are less than 200, it protects against PCP and toxoplasmosis only. GI infections, I think, are variable, but generally it's toxo and PCP that it prevents. And if if Septrin is contraindicated, so for example, if somebody's got an allergy or if they have a G6PD deficiency, then there are alternatives. What I'll do is I'll post the alternatives in the chat. But the alternatives often don't cover sometimes they don't cover the other infections like toxoplasmosis. So I'll post some in the chat now. Um, and then vertical transmission for the baby with late diagnosed mother, what you can do. So with HIV and vertical transmission prevention, number one is getting the mum on antiretrovirals. I know you've mentioned late diagnosis, but you can give higher or more antivirals. So although triple is standard, so where you give three antiretrovirals, you could put in a fourth one, so that you can really try and get the antiretroviral done as quickly as possible. If the viral load is, I think it's greater than 10,000, you could also give IV and AZT, and then that's sort of the main thing that you can do. The other thing is trying to get the mom tested earlier, but obviously I appreciate particularly in the war setting, women may not be able to get tested because of routine antenatal care and so on. So the main thing is just I would say go for quadruple therapy. And then the mother, cesarean section would be better if you're not able to get the results of the viral loads quickly, to see if they're undetectable and, to do a normal delivery. And then the baby obviously should get PEP. And the mother should do formula feed. And again, I know that's going to be difficult in the war setting because of, maybe access to milk and formula as well. So I think that's really all you can do is maybe, so I would say 4 drugs. Do I hope for an HIV vaccine? Always, 100%. The last vaccine that I think that showed good results was about 40% effective, so not enough to be able to use in the population. But we were talking about PrEP earlier, and there has been lenacapavir, which was studied, and it showed really good results if you give it twice yearly, for preventing HIV, and it actually showed prevention of HIV by 100%. And I just think that can help with maybe finding prevention and vaccines. Very different mechanisms, but if you can give an antiretroviral twice a year injection and it prevents HIV, and the studies are showing 100% prevention, I hope, inshallah, a vaccine will come. Fluconazole prophylaxis, we don't tend to give routinely fluconazole prophylaxis for fungal infections, because, hopefully I guess fungal treatments can be a bit more toxic. So we tend to we don't tend to do it. Guidelines sometimes recommend it, and MAI as well. MAI treatment, if the CD4 count's less than 50, some people do give MAI prophylaxis. I don't tend to, but I've been brought up per se in the world of HIV that way. But some people do. I think if somebody's getting chemotherapy, then yes, fungal antiviral prophylaxis and also MAI prophylaxis can be given as well. Yes, you're more than welcome to have my LinkedIn. I will give you that. And also, I just want to put into the chat the PCP alternative suggestions. So just bear with me. Here we go. So this is the alternative. Sorry, I don't know if that's going to come out nicely, but you can see there's lots of different options. So you could give
Yes. I'll copy that and post it on
brilliant.
Telegram.
Okay, brilliant. You can give dapsone, is an option. Dapsone with pyrimethamine and folinic acid. Nebulized pentamidine is often difficult to give, and atorvaquone is another option as well, with or without pyrimethamine. But you need to give folinic acid as well. What I'll do, Rayan and Sarah, is I'll add that to the slide set that I've got, and then you've got it in the slide set as well. Sorry, there was another question I think I saw. Oh, my LinkedIn account, I'll give you that as well. I'll give it to Rayan to forward in the chat if that's easier. If a person living, sorry, I keep missing it. Where is it? Um, if a person living with HIV is on and a sustained viral load, are they still infectious? No. So 100% not. So if somebody living with HIV is on treatment, they're taking their tablets, they've got really good adherence, and it's 95% or above adherence, and they remain undetectable, they cannot pass HIV on. And we say that we can say that with confidence after they've been undetectable for 6 months. They will not pass on HIV. If I was to take blood, this is what I say to my patients. If I'm to take blood from you and I get a needle stick injury, I don't need to do anything. I don't need to take PEP. If that person was to have sex with somebody, they will not pass on HIV. The person does not need to take PEP, and the person also does not need to take PrEP um, to prevent HIV because they will not get it. They only need to do that if they have more than one partner because there could be a risk outside, so they don't need to do that. And the other thing I say to patients is that it means also if you wanted to have a baby, you just conceive naturally, you have sex, and you can have a baby. You don't need to do anything special because you're not going to pass on HIV. So I think explaining it that way, and particularly when I say to them, if I get a finger prick and I don't need to do anything, that really is a big change. And I think it also helps understanding in general. So they cannot pass on HIV at all. Somebody also mentioned urological and conditions and HIV. There aren't really anything specific, I think, with the urology tract. If we're thinking bladder, prostate, the main thing I would just say is cancer in general is a greater risk. Stones can be seen with some of the antiretrovirals like atazanavir, but otherwise not much. And then the kidneys I mentioned in the talk. Biologics for HIV treatment, do you mean immunotherapy and so on? Um, I'm going to assume so. So with biologics and HIV treatment, this is sorry, I'm just going to put this in because I've just copied and pasted where I've got the alternatives from. So with biologics, you can't really treat it for HIV, but they have looked into BNAB, so broadly neutralizing antibodies, as part of a cure for HIV. But you can use immunologics for people living with HIV. I've got quite a few patients who use immunologics, for example, for cancer treatments, for rheumatological conditions. You've just got to make sure there's no drug interactions. HIV and bone marrow failure. So it's not that I would say HIV wouldn't cause it, but you may get like malignancies, or MAI could obviously affect the bone marrow, TB, but also when we say bone marrow failure, I guess expanding that, maybe you see anemia, low platelets. So with chronic HIV infection where it's untreated, you could get anemia, as in anemia of chronic disease. You can get thrombocytopenia, which is immune thrombocytopenia. The main thing is treating the HIV really, and you can see, neutropenia, lymphopenia in severe HIV. But again, it's about treating HIV, but also thinking about the other differentials to think what else could be causing that. And also some of the treatments, so Septrin can cause low platelets, or cotrimoxazole can cause low platelets. A lot of the treatments for OIs can affect the bone marrow as well. So it's a really, really good question. Any patient confirmed as HIV for initiation of TTT? Sorry, what's TTT? Is that TB? Sorry, if you just let me know when you say TTT.
Is treatment.
Sorry, what's that? Say that again.
Treatment.
Sorry, you said I can only hear the treatment.
So TTT stands for treatment.
Treatment. Oh, right. Okay. Oh, just treatment. Okay, fine. So any patient so basically anybody who has HIV, you would get them onto treatment nowadays. But so anybody with HIV, if you see them, they need to be on treatment, but they need to be ready to start treatment, and you need to make sure there aren't opportunistic infections, because if there's opportunistic infections, you treat first and then you wait 2 weeks and off longer in other infections like cryptococcus, and then you start the antiretrovirals. I would say treatment of HIV is like a whole other talk within itself, but ultimately, somebody living with HIV, there's no reason not to give them antiretrovirals unless for whatever reason they don't want to take treatment, which we do see. So unfortunately, some people don't want to be on treatment. When you say is it the same for blood transfusions, what do you mean? Is that around, if you just clarify, causes of seronegative tests in people known to be HIV tests? So is somebody living with HIV, it's rare, but it is possible they could test HIV negative. That may just be a laboratory error. It may be a false negative. But those, I would say those are the only reasons. I've never seen it in the context otherwise. There were people that have been cured for HIV and they have been, I think they've tested negative. Sometimes also if people are on PrEP or PEP, that could make the test seem negative when it's actually positive. So you always remember back to your window periods and make sure the person retests. So somebody said, sorry, somebody's just said treatment. If you just clarify what you mean, and then also, is this also the same for blood transfusions? What do you mean by that? This is great, the questions. I wasn't expecting so many questions. I know some of them are more general, but which is great. I'm more than happy to answer.
Yeah,
It makes me feel useful. So,
indeed.
and I'm glad there's interest.
Glad to
Right, Rayan?
I think she's an issue with her phone, and I reckon we came to an end.
Okay.
Thank you very much, Dr. Sadig Omer and Dr. Nadia Ahmed, for these insightful and comprehensive presentations. Your experience has greatly enriched our understanding and clinical foundations on HIV/AIDS, going from virology, basic immunology to the acute infection and clinical stages, systemic involvement. And we would also like to thank all the attendees for your active participation, engagement, and the thoughtful questions. And we appreciate your interest in our lectures. This reflects a strong commitment to improving HIV care and patients' outcome in our communities, especially the vulnerable communities. On behalf of the Tropical Diseases Teaching Hospital, the Academic Club, and the Sudan HIV/AIDS Work Group, SHOG, we extend our sincere appreciation to the speakers and all the attendees. And we hope you enjoyed today's session. So this concludes our second lecture, but this is not the end. Next lecture will be on the 27th, 7 p.m. Sudan time, and we'll go through treatment approaches. We have a local speaker from the HIV National Program and with the WHO guidelines, and Professor Nada Fadl to take us through the innovative therapies and updates in HIV treatment. Thank you again, Dr. Nadia. Thank you everyone for being with us today. And over to you, Sarah.
Oh, thank you so much, my partner in crime. This day has been a real amazing day, a roller coaster of things. We've been through immunology, microbiology, and then Dr. Nadia, she took us through the journey of HIV in all the clinical classifications and everything. It was really an amazing session as usual. And we are really humbled and glad and pleasured to have all of the participants and the speakers, of course, and being able to host those amazing sessions every single week is always going to be one of our greatest achievements through this year, 2025. Thank you, everyone, for always supporting us, for attending, for making time to come and join us in our sessions. And inshallah, we shall continue doing our best to spread knowledge. And of course, sometimes you might not be able to do a lot for our beloved country, Sudan, because most of us are far away from there. But we are going to try our best to help by spreading knowledge and making sure that we provide you with as much as we can so that we can help our country rise again from the ashes. And as we always say, Guafia, stay safe and peace out, and see you in the next session. Thank you so much and have a great evening.
Dr. Nadia.
Hello, yes, I'm here. Thank you.